Nature Symposium. So we have, I think, a really kind of fun session this morning. We're going to have a wonderful talk by David Frame. And then I think my favorite part of the symposium is where we get down and dirty with the pro-con debates. And then I think a wonderful topic in our area that deserves a lot more attention, which is late effects in our patients that we see. So just going over the meeting overview, as I think a lot of you kind of caught some of these terms here, is that we like to base NICER upon a childhood book. And so today we are into Saturday, which is The Lion and the Unicorn. I'll admit I've never read this book, but I guess there's a lot of back and forth between the lion and the unicorn. And so that's kind of the theme of today. And so it's all about understanding the impact of age on immune drugs, and we'll set the stage for some very fun debates later on. So I'm going to introduce our first speaker, and I have the privilege of introducing a friend and colleague, Dr. David Frame. So Dr. Frame, All right, so Dr. Frame is in cell therapy and immunohematology, pharmacist specialist at the Michigan Medicine, and a clinical assistant professor at the University of Michigan College of Pharmacy. Dr. Frame earned his Bachelor of Science in Chemistry from St. Louis University, as well as a BS in Pharmacy and PharmD from Wayne State. He completed an oncology residency at the University of Illinois of Chicago and has practiced oncology, hematology, and stem cell transplant specialist at Rush. Dr. Frame then joined the University of Michigan, where he is now faculty. And at the University of Michigan, he is active in caring for and optimizing therapy for stem cell transplant and chimeric antigen receptor T cell therapy, and has a lot of active research in a lot of very cool areas. And I'll just list a couple here, but he's very interested in developing therapies to both minimize toxicity and maximize response. He's also looking into the development of a new way to treat certain types of graft versus host disease. For those of you who have worked in the Michigan Immunohematology Clinic, Dr. Frame is very important to that clinic and is one of his most challenging areas that he works with per his biography. He has been active in many organizations, including the Hem/Onc Pharmacy Association, where he served as chair of the research committee, the International Support Care Oncology Pharmacy Practice. He's a scientific chair of the International Foundation for CDKL5 research for several years, and currently, important for us, is kind of really developing the pharmacy arm of NICER, which I think is obviously critically important for all of us and how we care for our patients. So I'm very excited for this talk, and may have the best talk title for today. Sorry for the other speakers, but Pharmacokinetics and Age, Which Rabbit Hole to Go Down? Work better if you just hold this instead of put up there. But
all right. Thanks, Jim. Greatly appreciate that. So nice to be here. My car always wants to drive to Rush, though, when I come to Chicago, because I was there for quite a while, and awesome institution. Anybody here from Rush? No? Oh, that's sad. Okay. All right. So I didn't realize the switch in themes between the days. So I'm back to still Alice in Wonderland and looking through the looking glass. So that'll be more of the theme here. But this is totally appropriate of going down the rabbit hole when you try to talk about pharmacokinetics, especially a lot of the information that we don't have in children and things that we still really need to learn. And so I'm sure you'll see a lot of that today. I'm going to go kind of quick. I tried to keep cutting slides, but then I kept cutting way too much information. So I'll go kind of quick. This was actually my backyard last year. We didn't have any rabbits. We had dogs, and we didn't have any rabbits until they passed away. And suddenly we, within 5 years, we have like 100 rabbits in our yard. So, but this is how I feel, honestly, a lot of days when Kelly calls and says, hey, we have a case. I really need some help with this. And I'm like, oh, which hole do I go in and which is going to be the most appropriate? Where am I going to end up? And so as we talk about this over age, one of the biggest differences I think is really more in the neonate and infant area. For the most part, as you start to become 3, 4, 5 years old, you actually start a lot of processes start moving more towards adulthood. And we'll go through these fairly quickly. But this is kind of the general definition of ages that I'm going to talk about. And this is an AI rendering of Alice over the years. All right, so, my slides aren't right. It didn't keep the sides. Okay, so when we talk about pharmacokinetics, this will make this even more interesting. All right, so when we talk about pharmacokinetics, obviously we think about absorption, distribution, metabolism, and elimination. And so I'll touch on each of these pieces and how they somewhat differ in different pediatric age groups. And so obviously we start with absorption. And when we think about absorption, obviously we think about primarily for oral drugs, the GI tract. And some of the things that we don't think about too much that we'll talk about for a minute here is when you think about absorption, it's not just the absorption. There's a lot of metabolism that happens in the gut wall. And that's a piece that I think we very often forget about and actually can potentially make a huge difference in how much drug is absorbed over different age groups. So when we think about absorption factors within the GI tract, and you're going to miss some of my pretty pictures. When we think about absorption factors within the GI tract, there's a lot of processes here to actually think about. So obviously the membrane physiology of the GI tract itself, the type of the cell membrane that's actually there, lots of transport processes. And I'm only going to touch on this. This could actually be a whole talk in itself. And quite honestly, I think a piece of medicine that most of us do not pay nearly enough attention to, and probably really changes outcomes with drugs. Some motility, emptying rates, drug stability, obviously the dissolution, the changes, the pharmacology changes that happen within the drug or the pharmaceutics portion of the drug. So drug stability, the pH of the drug, the pH of the GI tract, the surface area, all these transit issues. So there's a lot that happens just with absorption. We don't think about all these every day, but they really do change over time. And so when you look at gastric pH, for instance, typically in the first couple of weeks of life, and I know a lot of times we get called for neonates, right? And those are always the funnest. It's like, oh my God, I don't know. And so when we look at the first couple of weeks of life, they typically have a near neutral pH. And so you're going to get a very different drug dissolution a lot of times within those first couple weeks of life. And pH kind of slowly declines until about the age of 1 to 2. Usually around 2 is where you start hitting more of adulthood. And so depending on if it's a weekly acid drug or a weekly basic drug, you will have significant potential changes within with the absorption of different type of drugs. If we think about gastric emptying time and intestinal transit time, the gastric emptying time is usually also very much slowed down in those first few days of life. It starts to pick up usually around a couple weeks and really doesn't get to a fairly normal level until usually somewhere around 6 months of age, and usually somewhere closer to a year, you start to see more of adult type of motility. And so in the early days, in the first probably 5, 6 months, and especially in the first month, you're going to see potentially a lot of increased absorption because of decreased transit time. It has a lot more time to actually be able to absorb into through the intestinal wall. You also have a lower intestinal surface area. So that might even some of this out because you don't have all the villi and everything fully developed quite yet at that point. And so that will actually decrease the absorption a little bit. So it may even portions of it out, but in general, you usually will get an increased absorption in those early days with many of the different type of drugs, especially if they're weak acids or weak bases. And then obviously we have the gastric enzymes, right? And so we have The lipases, the amylases, they usually are much, much lower at birth. Those don't usually affect most drugs that much, but once in a while you will have a drug that actually needs those to actually get either metabolized within the GI tract so it can get absorbed, or sometimes it even helps with some of the absorption. And then obviously biliary excretions change dramatically. And that's really, really important, especially as we talk about glucuronidase drugs. And I'm going to spend a few minutes actually talking about glucuronidase drugs, because that's another portion that I think we really highly miss as we think about drug absorption. So if we look at intestinal P450, a lot of times in the very, very, very early days, your cytochrome P450 might be a little bit lower, not only in the liver, but actually in the GI tract. And so again, what that will mean is that you potentially will actually have less first pass effect going across the GI wall, right? So we always talk about first pass effect in the liver. That's not really true. That's actually second pass. The real first pass effect is actually going from the GI into the blood itself. And so you can actually have bioavailability changes up to 30 or 40% because of the changes in P450 in those in the first usually couple months of life. So if we look at distribution, this is challenging, okay, without my, if we look at distribution, I was going to say, oh, this is the wrong slide, but it's actually kind of correct, because if you look at this and you look at this, right, they look very, very similar. And so I think I often find myself down in that rabbit hole trying to now figure out which one to get back out of and which one makes most sense. But when we think about the distribution phase, it's sort of over here to the left. So the drug finally gets from the gut into the systemic circulation. Will first go to the liver, get that what we call first pass effect. But then there's a lot of things that actually start to make a difference. Is it bound to proteins, right? Is it bound to albumin? Is it bound to alpha-1 acid glycoprotein? Because those, as I'll talk about in a minute, actually change as well with age. Is it stored in a tissue? And that's an area where we need a lot of research. And I'll talk about that briefly towards the end. And then where is the site of action? And that makes a big difference on how we want to actually sometimes deliver these different drugs. So when we look at distribution, probably the biggest effect that we at least think about with distribution, when you're a neonate, and as you start to get older, you have a huge change in body water content and fat stores. So that's, everybody knows, that's like one of the big changes, right, from that squishy little baby as you start to grow. But you do get differences in plasma protein concentrations, you get acid-base balances changes, you get cardiac output changes, and you actually get significant changes of blood flow to tissue, which will actually make a big difference on where you want that, your outcomes based on where you want that drug to actually get to, okay? So if we think about body water, 85% of a premature infant and 75% of a newborn is water, okay? So they're squishy little sponges, right? But what does that mean? Many of our drugs are water soluble. And so that means in the younger patients, they actually have a much larger volume of distribution, right, for a water-soluble drug. And so very commonly, that actually means that we may need a significantly higher dose and maybe even a loading dose in those patients in order to be able to really cover that much larger volume of distribution. As you get older, you start to get down to about 60% body water, and eventually you end up with about 30% fat tissue until you get my age, and then you get a lot. And so I'm not really talking about the older age spectrum today, more of the younger age spectrum. But there are obviously some of these same issues that go on in older age that almost revert a little bit back somewhat to what we see sometimes with kids. So protein binding. So when we think about protein binding, we often have, so remember with a drug, right? The most important part of the drug is the unbound portion. Most drugs bind fairly heavily to proteins. And so it's the unbound portion that's active. It's also the unbound portion that drives the clearance. okay? And especially for hepatic extraction drugs, what we call high extraction drugs, it really, really depends on unbound drug of how fast that drug is actually cleared. And so remember, acidic drugs tend to bind to albumin, whereas basic drugs tend to bind to alpha-1 acid glycoproteins. And so you definitely get significant changes from, again, for typically that first 1 to 2 years of life, where you tend to have less albumin and alpha-1 acid glycoproteins that then get that start increasing usually until 3 or 4, and then actually get to be more of adult type of levels. And so you'll have a little bit more unbound drug, and so you may have more active drug in the younger age. Again, I'm going to come back to liver glucuronidation a little bit, but again, that's often much, much slower in the younger pediatrics. Cytochrome P450 is a difficult one because depending on the studies you look at and how they're done, you will actually find kind of all over the board how P450 actually changes over time. And in general, when you look at it, and so this is looking through the looking glass part, okay, because remember in that story, everything was opposite of what it should have been, right? And so that's sort of what we see, I think, with a lot of the drug metabolism in the younger children, because overall, when you look at all these factors I'm talking about, right, some are going to increase the amount of drug, some are going to decrease the amount of drug, and they all have different activity based on the binding, okay? And so when you put all of these factors together, for most drugs, you would actually expect that the young pediatrics, so especially less than 2, would actually have less metabolism. But in most common scenarios, it actually has more. Okay. And so that's the looking glass part that really still means that we don't fully understand how all of these factors actually work together in order to do this. And then obviously we all know kidneys for renally cleared drugs or partly renally cleared drugs make a big difference. The one drugs that really tend to fool you, and sometimes we don't even know this happens, but a lot of times if you have a more hepatically cleared drug and you have decreased hepatic metabolism, the renal will actually pick up and actually kick out more of the drug, and opposite is true as well. That happens a lot with Tacro. We see this a lot in the transplant area, where you'll get damage to one organ, the other organ will actually end up picking up more of the metabolism of the drug. And so definitely we see significant changes over the lifespan, right? And so how do you really decide? And so this is the call, I get. And my answer usually is, I'll call you back in about an hour or 2. And it's because honestly, I'm going through all these factors and trying to make the most clear decision based on these different factors. Now, there are some programs out there, and these programs have actually become much more developed over the last several years. And honestly, 15%, I think, of the applications to the FDA now for pediatric indications actually use modeling to actually be able to go to the FDA with the drug dosing for pediatrics, sometimes without a whole lot of actually true clinical data. And so usually what happens, I'm going to go through one of these examples. So when I thought about this talk, I'm like, okay, what are we using in immune heme these days? And right, it's a lot of TKIs, a lot of tyrosine kinase inhibitors, and it's a lot of monoclonal antibodies. And so I'm kind of going to stick mostly with that theme for the talk, because again, just not enough time. But usually when you put these models together, okay, and I'm going to go through this very quickly, but when you put these models together, usually you have to do it in adults first, because there's actually usually adult data, right? That you have real life kinetics, you have real life drug levels. And so you can create a model that actually fits to adults, right? And so the example I'm going to give you is imatinib, and I know this group probably doesn't use imatinib that much, but it's a pretty good overall model for TKIs, okay? And so that's what they did in this study, where they had all the adult data, they put it all together, they created this model, and then you take this model to peds, okay? And usually you don't have a whole lot of data at that point in pediatrics. And so what you basically do is take all of those variables, only even a little bit more, okay, that I just talked about, and this is what it would look like, all right? So you look at absorption portion, right? And so they put this model together where you look at all the physiologic properties of the drug. You look at the molecular weight, you look at the ionization, you look at the dissociation coefficients, you look at how much is unbound as it goes through the membrane. You look at plasma binding component, and so that's the first part of the model. Okay. And then you start to look at the absorption phase. Okay, so that's the dissolution phase. Now you look at the absorption phase, and you look again at how much unfractionated, how much flow is there to the liver? What is the liver size? All of these things actually go into this model, and then you start predicting the distribution. And usually there's models that are already done by the time you get to the FDA that have actually tried to use in vitro data. In vitro data in order to try to, and usually these are often live microsomal enzyme type of systems in order to try to put a lot of these type of pieces together. So you look at volumes of distribution, you look at elimination phases. And so for imatinib, we primarily think about 3A4. But honestly, there's hardly a kinase out there that actually goes through one CYP enzyme. They all at least partially go through 2, 3, 4 different CYP enzymes, just like they tend to bind to 10 different targets, right? And so when you start doing this, they first did the 3A4, but then you have to do the portion of like 4% goes through 2C8. And so you have to do this iteration 2 or 3 times, first for the gut wall and then for the liver, okay? So you go through all of these variations and come up with a model for the clearance of the drug. And then again, this thing keeps popping in, these transporters. And this is, again, something that very rarely, I think, clinically do we take into a whole lot of consideration yet. But there's many, many different transporters. A lot of these are what we think of in cancer as multi-drug resistant transporters. These are all the same type of genes that actually transport drugs, both in and out of the GI tract, in and out of the liver, and into cells, okay? There's been some really interesting case reports recently where some of our newer drugs are actually inhibitors of certain transporters. So actually one very unique one that just popped up that was not on my radar at all, the new febuxostat. Whoa, did I do that? Actually inhibits multi-drug resistant protein for nuclear transport. And so there was a patient who was on ganciclovir and ended up having agranulocytosis, which we know happens with ganciclovir, but it was really severe. Well, the febuxostat actually pushed so much ganciclovir into the cell because it actually changed the transport system that the patient actually almost ended up having marrow failure. And so very interesting how we don't always think about these transporters, and makes you suddenly start to think, I can't figure out what else is going on, why this is a problem. Maybe that's actually the problem, because there are a lot of drugs that affect transporters that we don't think about all that much. And then you actually start to look at the differentiation of data that we know of hepatic enzyme function in pediatrics versus adults. And so again, you can't just look at hepatic, you have to look at intestinal as well. And so one of the things that I think often bypasses is we have so many patients, right, that are on P450 inhibitors or inducers, right, Vori, Poza, all these drugs. One thing that's very common that I think we also tend to really miss is if you're on an IV drug, so let's just take Tacro, for example. If you're on IV Tacro, right, and you're on Vori, okay, you're getting the liver change that actually happens from the Vori, right? But once you change the PO Tacro, you actually need a different conversion, because now you're changing the P450 in the gut as well as the liver, right? So it didn't affect the IV Tacro, right? But now it's going to affect the absorption of the PO Tacro. And so a lot of times, right, you make your conversion, you're like, wow, that came out wrong. Well, that's probably why, because it actually can make sometimes almost a 35% difference in what the level of Tacro ends up being, depending on if they're, how much you're changing the P450. And so there's all these models from, again, in vitro data and some in vivo data, where you look over the age span and you see differences in fraction of enzyme activity. You see differences, in this case, alpha-1 acid glycoprotein. Imatinib is a weak base, so you're more worried about the alpha-1 acid glycoprotein. If it was an acid, you'd more worry about albumin. You look at the liver volume, because the volume actually ends up making a big difference on how much hepatic function, enzyme function that there actually is. So you put all these models together, okay? And finally, you start to put equations in, all right? And so you look at the protein binding, you look at the adjustment for the unfractionated adjustment for PEDs, the changes in liver volume, and you come up with a final equation. And then finally, okay, you actually come up with some dosing. And it's very interesting because, again, in the early days of imatinib, the PEDS dosing, right, we love to dose based off of some type of body surface area, right, or body weight. We take adults and we just say, oh, the kids are little adults and we're just going to adjust it by body weight. And that usually doesn't work, okay? And this is a great example because in the early days, they usually use more of the 230 milligram per meter squared. And if you look at the levels compared to 460 milligram meter squared, so these are 2 to 5-year-olds, 6 to 11-year-olds, 12 to 17 and up. And you can see that you really need a much larger dose of imatinib and PEDs in order to get an equivalent of what you would see in adults, where all the data is to say this is the amount that you actually need to get good inhibition and good outcomes. But that's not quite enough, which is what the should have said on top. When they first did this model, it didn't actually come out correct because one thing they forgot, imatinib actually changes P450 itself and actually changes its own concentration. So they actually overestimated on this model because they didn't account for the clearance of the change with imatinib itself. Okay, and that brings up the whole issue of drug enzymes and drug interactions, right? And so all these drugs that have interactions have very different amounts of change to the P450 system. We just say, oh, they're strong inhibitors, they're strong inducers. Well, no, that's not really correct, right? They're really 20% inhibitors, 50% inducers. And sometimes it's really hard to figure out exactly what that data is. And we often just kind of ignore it and say, oh yeah, it's strong, it's going to be a threefold difference, okay? But you really need these type of equations to say that. And this, again, I don't know why these aren't showing up very well, but these was supposed to be divided out between sort of moderate and weak interactions. And actually you tend to see more age changes with a little bit more drug interaction, okay? And so you tend to get more changes in the younger group with these drug interactions, probably because of difference in enzyme activity at baseline, okay? So sometimes we actually have really nice literature we can go to, right? And that's really helpful. And so this was actually from the Cincinnati group looking at ruxolitinib, a drug that we probably all use a ton, right? This is now the drug, right? For almost everything. But again, when you really do all the model predictions, you would actually expect 2-year-olds to actually, 2 years or less, to actually have lower clearance of the drug. But this was done by the Cincinnati group in patients with graft versus host disease, and actually found that you have almost 2.5-fold higher clearance in younger patients. Okay, and so this is why when Kelly calls me and says, "Oh, we have this, 6-month-old," I'm like, "Okay, we're going to give a really big dose," and she's like, "Are you sure?" And I'm like, yeah, this is what I want to do. And I'll go into this again in a few minutes, but I'm a big believer, and I'll get to this as to why, but I'm a big believer, especially in very acute situations, of really giving a lot of drug. I'm a loader, okay? I'm a loader. I'm not a minimalist at all when it comes to giving some of these drugs. And I'll explain a little bit more, and it makes even more sense, I think, with monoclonal antibodies. But as I talk about monoclonal antibodies and targets, the same principle actually does hold true for tyrosine kinases, okay? Because your target actually will change depending on the amount of inflammation and the amount of cells that are actually present. We don't think about that much with small molecules. We think about that more with monoclonal antibodies, but the same principle actually very much holds true in small molecules as well. Wow, one showed up. Okay. And so if you really want to go down the rabbit hole, okay, this is where we go. And this is why we all are here, right? Because we all love inflammation. Nothing like it, right? But it will definitely set you into a free fall down the rabbit hole. All right. And there is a lot that we don't fully understand about how inflammation really changes a lot of the different systems that I've already talked about. It changes protein balance, changes excretion and catabolism of proteins. And so you get different albumin levels, different alpha-1 acylglycoprotein levels. But one of the biggest things that we actually see that, again, we never talk about hardly, at least at Michigan, I think about a lot, and I actually kind of take it into some of my calculations in my head as I'm trying to figure out a dose. But you tend to get a lot of down regulation of P450 in the early days of inflammation and in chronic inflammation. Okay. So again, it really kind of varies on the disease state itself. But in the early days of a lot of inflammation, you can see a really significant decline in P450. And so that actually goes totally against what I just said of I like to load, right? Because now you should be thinking, Frame, you're a little nuts here. Are you the Mad Hatter in this story? And sometimes I think I am. And I think other people sometimes do too. But what you have to realize is that as you start decreasing that inflammation, the P450 will change quickly. Okay. So yeah, am I giving a little bit too much drug sometimes on those first couple of days? Maybe. And I hate to give this talk because sometimes, we do things that we don't always explain to people. I should never say that, right? But it won't change my approach. But I do know that probably I am giving even a little bit effectively more drug with my load than just the load itself, okay? Because I'm not getting as much clearance in those first few days. But it doesn't take long at all, okay, for that clearance to actually change back. So the other thing that you can't be fooled with here, right? And especially if you're not giving bigger loaded doses up front, right? You're giving a drug and it starts to work, right? You're like, oh, great, I'm going to back it down, okay? Well, your clearance actually now went way up, okay? It's working, right? So your clearance actually went way up. So now you're backing off the drug thinking, oh, I'm safe, I can decrease some of the toxicity and back off. But no, now my clearance is actually going up. So if I back off, I actually may really be backing off because now I'm getting a lot more clearance of that drug as well, okay? It's a big part of the P450 that, again, isn't 100% understood and actually probably involves all of these transcriptional mechanisms that actually changes the P450. But when you look at these transcriptional mechanisms, it's very interesting, right? Because a lot of them are involving inflammatory factors that are actually playing a role in the disorder. And so this actually may also be partially how these drugs are actually working through changes in P450 with some of the outcomes that we actually see. So that's a real rabbit hole to go down. That's actually a lot of fun, but boy, I'm lost way down there somewhere that hopefully someday I'll get the right path back out. And this was actually a really interesting study done a couple years ago in kids with sepsis in the ICU. So early sepsis, lots and lots of inflammation. They looked at clearance. They looked at 3A4 metabolism based on midazolam. Okay, so activity of 3A4. That's if you ever need to really know if you ever really know that 3A4 is actually on or off or how much, just give a little midazolam and measure the level, and it will clearly tell you how much you're actually metabolizing, okay? And so they looked at this based on body weight, and sure enough, lower body weight with sepsis actually had significantly lower clearance, okay? But then they took body weight and actually added in CRP concentration. And depending on what you're a believer in, CRP is sort of a marker of IL-6 to some extent. Probably not as much as a lot of people make it out to be, but to some extent it is. And I will tell you, the majority of literature out there for changes in P450 is actually induced by or decreased by IL-6. okay? Which really makes this interesting when you think about CAR T, when you think about things that go on with transplant. A lot of this data really came out with COVID, right? Because there was so much data with COVID, but IL-6, thought was to be a driver of COVID. And that's where a lot of data actually started really coming out, understanding that this is much more important than we probably ever thought it was. But very interestingly, if you divide kids up by age, by weight, so 60 on the top, 10 on the middle, 3.5. And now you not only look at weight, but you look at inflammatory factors. These kids drop off the chart actually for clearance. Okay. And so yeah, you will get a dramatic change as you start to change those, that inflammation. Okay. So again, if a drug's working, you back off, or if a drug's working and you don't back off, right? And then things start getting worse. Well, it's because clearance actually significantly started to change. So you may often need more drug than you actually thought you did to begin with. Does that make sense? Okay. All right. Now, one of my favorite topics, and one that I've been pushing for years, to say if any drug needs to be therapeutic monitored, it's probably mycophenolate, right? And we use a pretty decent amount of mycophenolate. So when you look at mycophenolate, it actually goes through glucuronidation as its primary pathway, all right? And as I'm sure you all know, the key to mycophenolate is enterohepatic recirculation. 60% of mycophenolate is actually bioavailable due to enterohepatic recirculation. You will not get more than an hour's worth of mycophenolate, even if you give it IV, okay, if you don't get decent enterohepatic recirculation. Within an hour, it's all glucuronidated, okay? And so people always think, oh, if I give it IV, it takes all that other stuff away. No, it doesn't whatsoever, because it all gets back into the gut very quickly and actually needs to slowly get deglucuronidated and actually reabsorbed into the systemic circulation. And so we have all of these different glucuronide transferases that actually metabolize mycophenolate. So does this get curiouser and curiouser? Yes, it does. And so very interestingly, so usually overall, okay, you tend to have, depending on the timing, you tend to have 40 to 50 times more glucuronide than you do active drug, all right? Because the glucuronide is not active, all right? So like I said, even if you give this IV, typically within an hour, it's almost all glucuronidated. You have very little free drug that's actually available to actually work anymore. But very interestingly, in pediatric patients, there is a significant increase in actually active drug compared to adults. It's still low, okay, but it actually is significantly more than what we tend to see in adults. And this drug is actually what we call a moderate extracted drug through the hepatic system. And so it's actually affected by the liver flow. So again, depending on the inflammation, the liver flow will change tremendously, okay? It's changed by the free fraction, and obviously it's hugely changed by the intrinsic activity of the liver. And you start to take bacteria away, right? So all these patients end up on antibiotics. You start to take bacteria away that do the deglucuronidation, and now you're not having much recirculation whatsoever. And so this is why you tend to get levels that look like this when you actually start to monitor patients. You get a ton of patients that are actually pretty low. You get a few that are pretty high. Yeah, you get more that are sort of in that middle range. And not only antibiotics, but also drugs that we tend to use in our populations like cyclosporin or Tacro actually change the glucuronide uptake. And so very interestingly, if you look at mycophenolate with cyclosporin, you actually get almost a 3-fold decrease in levels of mycophenolate than if you're using it with Tacro, okay? And that's because in the right here, cyclosporin actually blocks the glucuronide from being uptaken through the intestine and blocks your enterohepatic recirculation. So you don't have nearly as much mycophenolate actually coming back into circulation. So one of the things that we really should be doing is monitoring AUCs of this, right? I tend to get a trough level because that's what's available to us, if you can, right? But honestly, it's hard to really interpret those. It's really hard because it's one single point in time. And the enterohepatic recirculation, again, is very consistent over time. And actually, usually about 6 hours after you give the drug, you will even see a second peak of the drug because suddenly you get a whole bunch that's actually absorbed at sort of as it's emptying. You'll get a decent amount that's absorbed at one time. So you will often even see a second peak when you actually do kinetic studies on these. But obviously trying to get 12-hour levels in somebody is almost impossible, right? But I do want to make, most of you aren't going to be able to see this, but I do want to make you aware that there is some new technology that's now been FDA approved to actually use these capillary patches, where it's actually very, very easy for families to actually be able to put a patch on. And then they actually can just take the patch off. I stored in the refrigerator. And so you can get your whole AUC while the patient's at home. And the head of our kinetic department actually has now developed a validated assay that we can do this with mycophenolate. So I'm actually starting to get this up and rolling in our bone marrow unit at Michigan so that I can actually hopefully fairly easily measure AUCs of people at home instead of just really having no clue where they actually are. Okay. So how does this change with age? I think I mentioned this already, but glucuronidation often goes way down as you are younger, okay? And so if you look at neonate and infant, you tend to have about, again, a third of when you're a child, and that's usually somewhere around a half of what you have when you're adult. And so we actually ran into this, sadly, a few years ago that really made me probably start thinking about this more than ever. But in our pediatric bone marrow transplant unit, we were having a decent amount of veno-occlusive disease, and it was primarily in younger children. And so when I looked at the concentrations at steady state, essentially clearance, if the PEDS patients were less than 23 years old, they had much lower steady state concentrations. And so at Michigan, we don't do our own levels. We have to send them out. So we get the results back after the second dose. And so anything you need to make up, we make up in the third and fourth dose, right? And so it turned out, because these were so low, our third and fourth doses sometimes went up by almost 100%. Like, it was crazy how much we were increasing them. But one of the things that we weren't thinking about is that you could significant decrease of plasma glutathione after BuSci regimens, okay? And most of our VOD was in BuSci regimens. And so if you look at the plasma glutathione, it totally correlates with busulfan clearance. So very low glutathione really decreases busulfan clearance. So I hate to admit this, but now think about what we're doing. Right? So our concentration came back really low. We're going to really increase the dose on day 3 and 4. But what happened to our glutathione on day 3 and 4? It tanked. So now we thought we were giving the right dose, but we're actually giving a toxic dose, right? Just think of Tylenol, right? That's basically what this is. We're actually giving a toxic dose of Tylenol. So would it make sense that we get VOD? Absolutely, it totally would. And so sure enough, what we found was this was almost all in BuSci, very, very little in Flu-Bu. And then we started to realize that cyclophosphamide also is glucuronidated. So that's actually using up even much more of the glutathione besides the age problem, okay? And so sadly, we learned this kind of the hard way with a fair amount of cases of VOD, and then obviously changed our protocols to actually even this out over time. And I'm a big fan actually of giving NAC with these type of regimens just to make sure that you have enough free thiol around to be able to do this. Now, again, if you want to go down through a bigger rabbit hole, there are a lot of functions immunologically with glutathione. We don't think about that. We tend to think more about the drug issue if we think about that, but there are actually a decent amount of functions, especially through the MAP kinase pathway. So this is another whole system that actually changes with age based on changes with glutathione, okay? Okay, and then one thing I'm not going to touch on except for here is you also have to remember about polymorphisms, right? So all of what I said so far is clear as can be, easy to do, right? Yeah. But now you start throwing polymorphisms in that we very rarely check on people. And that totally changes your concentration. And probably polymorphisms play more of even have higher significance as you're younger because of all those differences I've already talked about. Okay. Okay. I have 9 minutes left to talk about antibodies. All right. So Obviously, we use a ton of antibodies, right? We all know that they're very hydrophilic, large molecules. And so most of the time we're looking at proteolytic degradation in order for most of the clearance after it binds to a target, right? We usually say monoclonal antibodies are not cleared through kidneys, okay? I just do want to point out, and again, a lot of this can be pediatric data, people with nephropathies actually can lose up to 75% of their this was a rituximab study. So the more protein excretion on the bottom means more higher molecular weight excretion. And so you had almost a 75% faster clearance of Rituxan in people who had some of these severe nephropathies, all right? If you look at distribution of monoclonal antibodies, it's usually mostly 1.5 to 2 times blood volume at most, okay? Very hydrophilic, very big. It doesn't get out of the vasculature very well at all right? Which is a whole nother issue that I will very briefly touch on. But if you think about what we talked about at the very beginning, volume of distribution, those little squishy kids, right, are going to have a much higher volume of distribution of monoclonal antibodies. And so once again, my theory of I really want to load them is partly based on this, especially in the little kids. We had a very, very young child that needed alemtuzumab, and everybody thought I was a little bit nuts with the dose I was actually giving, but luckily it actually did work out. Sorry, I'm going to skip through a little bit of this quickly. So the biggest issue with monoclonal antibodies for clearance, right, is that they have a target. Right. So if you think about, so the perfect example of this was actually Rituxan in the very early days where we were treating non-Hodgkin's lymphoma. The very first dose of Rituxan had a half-life of 3 days. All right. Because it was all getting bound to the receptors, right? Because there's tons of receptors there. Okay. After the second dose, it was about 7 days. After the third dose, it was about 14 days. And after the fifth dose, or the fourth dose, it was right around 21 days where you would expect an antibody to be. So this is the biggest thing and why I love to load monoclonal antibodies, because I want to hit all those receptors. If I don't hit all those receptors, everything's continuing to do what it does. If it's inflammatory responses, it gets bigger and bigger. And so you're already behind the 8 ball by the time you're ready to give the next dose. Okay. And so giving the next dose may be starting all over again. Okay. So this is why I really love to actually load monoclonal antibodies, especially. This was clearly shown and used a lot in bone marrow transplant. When you look at alemtuzumab and absolute lymphocyte counts, right? Makes perfect sense. The more lymphocytes that are there, it will eat up the alemtuzumab, right? And so when we think about these regimens of, especially conditioning regimens, we don't really want this drug around for 5 months, right? Usually, depends a little bit, but not usually, because that's where we see all our infections. And so dosing based off of ALC makes a lot of sense, okay? And this was, again, Cincinnati data, but they even looked at this based on different disease states. And when you expect that disease states that have a lot higher proliferation would actually have a lot faster clearance of alemtuzumab. And that's exactly what you find as you look at these different disease states. This was a beautiful example. This was a patient who was actually being transplanted. They gave the alemtuzumab, the levels are in the blue. They actually had an HLH flare after transplant. Look what happened to the alemtuzumab. It got eaten up immediately by that HLH, by all those cells with the HLH flare. So again, don't be stuck on this is a standard dose that we use, okay? Because it doesn't usually make sense. All right. I'm going to skip a little bit here. All right, I'm going to talk about this 30 seconds, okay? Once you've saturated the system, right? Once you've saturated the receptors, then you're looking at non-specific clearance, right? You're looking at more of a proteolysis type of scenario. And so typically what happens with these antibodies are endocytosed, they actually go into cells, but there's actually a recirculation mechanism. And I won't go through that whole mechanisms, it's here, and I'm sure you'll have access to these slides, right? But there's a whole change, and based on pH and enzymes, it looks like you will have actually a higher clearance or recirculation in pediatrics than you actually tend to in adults. And so that could actually change a little bit of your longer term monoclonal antibody levels as well, okay? Drug companies love to change these molecules and usually for a good purpose, but glycosylation of monoclonal antibodies will make a big difference on how fast they're actually cleared, okay? It'll also make a big difference on their function. And so if you look at CDC versus ADCC versus direct killing, you take away the fucosylated group on basically on Rituxan with obinutuzumab, and you totally change how that drug's actually working. And that can be really important if you have patients with complement disorders. All right. So a lot of times I'll recommend one drug or another if we need something like this in a patient who would have a complement disorder, because the function of the activity of these drugs will be totally different. Right. So we love to use weight-based dosing. It stinks. Okay. But we love to use it because it's easy. We love to use allometric adjustment. Right. Again, are you just, a smaller size? It works okay sometimes, but it's not the best, all right? And so one of the really unique ways of doing this is to do a pharmacometric approach, all right? And the example I'm going to give you here was actually done with emapalumab. Very, very great example, actually, of using a pharmacometric approach. So they did population kinetics, and then when they went into their trials, they actually looked at interferon levels. They looked at a biomarker, right? Because interferon's not always reliable. So they looked at a biomarker, CXCL9. They looked at disease activity. So they used different standard markers that we use to look at disease activity. And then they actually measured free versus bound concentrations. And so they put that back into their population model, were able to separate out the safety and the activity, and came up with the dosing of what they did, of basically to dose differently over time depending on response. No offense, guys, I think they did it backwards, but it's a beautiful way to actually look at how you, the right way to actually do these type of approaches for monoclonal antibodies. It's the perfect way to be able to balance safety and efficacy and really evaluate it based on the activity of the drug and the activity of the disease, not just some doggone body weight, okay? All right. These are just more examples. But the last thing I want to talk about is where the heck are these things working? Okay. So with some inflammatory disorders, we're really trying to hit cells in the blood, right? But with some inflammatory disorders, we're really trying to hit cells in tissues. Like I said, these have very low volume of distribution. They don't go into tissues very well. And so a lot of times we may need a much, much higher dose of drugs to actually get in tissue. When we're trying to extrapolate data of these type of drugs and even TKIs and these other drugs from chronic populations to acute inflammatory responses, you have to be very careful because, again, in most of these chronic conditions, they had time for the monoclonal antibodies to build up over time because they have a long half-life once you saturate the receptors, right? We don't have that luxury. So you can't just look at those type of studies and say, oh, that's how they dosed it there, because your child will be dead before you actually get to enough drug to be able to treat them, okay? And even in Crohn's, this was a really classic where they actually started front-loading people and actually had significantly better outcomes than trying to wait for 12 weeks to actually get enough drug on board to have a response. And so my slide didn't make it. Okay, so I've actually been doing this with Crohn's patients, with pediatric Crohn's patients, and we're actually even now finding that there's a significant difference in inflamed tissue. So I'm actually measuring tissue levels of infliximab. They don't correlate very well with blood levels, and you get significantly different amounts in inflamed tissue versus with non-inflamed tissue. And so that's partly why, again, you probably need a lot more of these drugs depending on where you want them to go. Okay, last thing, yes, I'm done. Okay. We do now tend to give some of these sub-Q or IM, right? Just remember that it will take usually 3 to 7 days to get a full absorption of a drug, of an antibody. So if you're, again, expecting a fast response, you may not get it depending on if you're giving it sub-Q or IM. If you do have hyaluronic acid in, it does speed it up by a day or two usually, okay? All right, so there were quotes to go along with these things. But I think the first one is, you can chase the rabbits, but you'll never really catch them. That's honestly how I feel a lot with my job, and especially with age and pharmacokinetics. I'm not sure I'll really ever catch them, but hopefully this puts into perspective a little bit on how we should be thinking about catching them, and at least some adjustments to the way the holes are actually being made, okay? And again, a little bit mad, yeah, probably. And this is me on a Friday after Immune Heme Clinic, waiting down the rabbit hole to wait for Kelly to call and say, "Hey, I got a case for you." And here's a free fall through the immunoheme, the zebra immunoheme rabbit hole. All right, thank you very much, and I'll be happy to answer any questions.
Okay, thank you, Dr. Frame. That was an amazing talk and gave us a lot to think about and think about. So we have a few, we can take a few questions. I'll start with one. So, given kind of the complexity of understanding the pharmacokinetics in patients, and again, I think you showed some of this data where, the plasma levels can certainly not correlate with tissues. And I think that last example you gave of kind of using this kind of biological response as opposed to looking at a pure drug level in the blood. And so my question is, kind of relating, because a lot of these studies were in patients who, may not have an underlying genetically defined IEI. And so then we have to add in that extra variable where even if this drug level worked well for a patient who had, inflammatory bowel disease, and now we're using it for a patient who may have, certain pathways that are, genetically turned on or turned off. Like, what is your approach to those patients, and as far as dosing them and using the data that you have in kind of a normal inflamed population, but now we're dealing with a much more complicated population?
Yeah. So again, as you actually already know, I do tend, if probably anything, I probably tend to overtreat a little bit at the beginning. I will usually take a risk of a little bit of toxicity in order to slow these type of processes down. And so, just as you said, and hopefully I pointed out, I really, 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 I use literature as a benchmark, right? Of this was the disease, this is the type of inflammation you see in this disease, this is where I need the drug to go, right? And I use that as a benchmark, right? And knowing that we have a totally different disorder, we may have totally different enzymatic changes, right? And it's definitely challenging when we don't know the disorder yet, right? Because it could be extremely variable depending on what that disorder actually ends up being, especially if you have mutations within like JAK or STAT or right. And so depending on what it looks like, depending on what everybody's thought is this looks more like X or Y or Z, is usually how I will start to make the call of I really, really want to be more aggressive here. Okay. Or I think we have a little bit of time. I will go for the safety and actually go a little bit lower to begin with. Give it a day or two, depending on the condition, depending on the state of the patient, and then sort of like the pharmacometric approach without being able to measure anything, just kind of say, I believe it's now time to actually make this type of change in the patient. But yeah, it's extremely challenging when you don't really know what the underlying cause is, because a lot of these causes have dramatic changes in these different enzymes.
Thanks for the great talk. My name is Alex Goldberg. I'm a product planner at Genesis Therapeutics. Just wondering, like, when thinking about developing new small molecules, like, what would be your wish list? What would you ask the medicinal chemists to pay a bit more attention to when thinking about drugs eventually being able to be applied in the pediatric setting?
Yeah, I mean, obviously the real wish list is at least a little bit of data in peds, right? Like in like clinical data. But that's definitely not going to happen. And so quite honestly, I'm a little bit for modeling without a clinical trial. I'm actually biased to the PBPK, the physiologic based approach. because the models that are used with those type of simulations are multiple. Now, are they perfect? Absolutely not. But quite honestly, when you look at most modeling, it usually comes out closer than most other models do. And so honestly, and I'm really happy that the FDA is accepting these now, because honestly, that's what I would prefer to see. If I can't have any real data, I would prefer to see the PK model. I think, and that's probably why I talked about it, but I think it's the most appropriate model to use. I think it gives us the closest estimate.
Okay, we're gonna have to move on to the next session. So thank you,
Thank you.
Dr. Frame. Of course, more questions can come up to him and he's always available. He's always a great help, for sure. So I think we have an award to give out.
Really quickly, anyone who's standing on the side of the rooms, if you could find an empty chair, only just to appease me as we play one quick game before we go into break. But before we go into the break and you find your empty chair, I do want to announce the Nicer Empower Award. And this award goes to someone who recognizes the commitment and willingness to share interdisciplinary care strategies with the wider Nicer community. They're aimed at enhancing confidence for both patients and providers in managing chronic illness. And I want to give this award to Dr. Eric Scott from the University of Michigan. Why we couldn't let you walk out the door. And thank you so much for doing all these patient care and provider care CME sessions with us and giving us all your knowledge. It's been an amazing year. Thank you so much for being part of us.
You're welcome. Yeah, thank you very much.
Oh, we have to take a photo together.
Oh, yeah. Of course. Thank you.
All right, congratulations. Now you know why we're trying to delay you for your flight, so.
I'll have to say, I'm not a hematologist, as you can tell. This has been a really great interaction for me to have to be able to really join your group. Kelly, amazing person welcoming me into your group. But I'll have to say, it's really been gratifying for me as a psychologist to really delve into and understand what you guys encounter day to day. And so it's been a really breath of fresh air into my career and professional development. So thank you very much.
Thank you. Okay, really quick. I see some people standing up. So if you can find an empty chair, really want to play a speedy, quick game. Please, please, please. Thank you. Okay, if everyone sees a copy of that book on the table, JP almost got ahead of me. If the person wearing the color at the table closest to the color purple and not their lanyard, but their actual clothing colors, the closest color to purple, please pick up that book. All right. Does that person have the book in hand? All right. Now that person wearing the color purple, please pass the book to the person at the table who arrived to the conference first. No, at the very beginning. Who arrived to Chicago at the Gwen first? So now that we know who came first, you should have heard who came last. So please pass that book to the person who came last. Next, if the person who arrived last could kindly hand the book to the person who traveled the furthest to be here today. So the person who traveled the furthest to be here today, if you could kindly hand that book to the person you met most recently at your table. Who did you just meet at the table? Now that person, please kindly hand the book to the person on your right, which would be all the way to JP for you. There you go. And if that person could pass to the person at your table whose birthday is closest to today, you are the winner of the copy of the book. Today's September 21st, who does not know? And congratulations, you're the winner. Thank you. All right, enjoy your break. We'll be back shortly. Thank you.
All right, we're gonna pro con debate at 10:15. Thanks, everyone. All right, if people can make their way back to the tables, we have a lot of people leaving flights, so we're gonna try to do our best to stay on time. All right, if people can quiet down so we can try to stay on track. Okay. All right, well, as I said, this is my favorite part of the symposium, of many favorite parts, but the pro con debates, which are certainly for fun. So for those of you who have not seen these before, we pick a interesting topic that may have some degree of controversy within our field, and we try to assign experts to that area. Sometimes they fight over what side they get to pick, and sometimes they just naturally gravitate to one. So, and as we learned with some of them, just because they present a particular side, they may actually believe the opposite, but sometimes that's the best way to do it. So we have two very interesting topics today. And so I am going to introduce our first debate. So Kelly Walkovich, who I think everyone knows Kelly. So Kelly, of course, she's the executive chair for NYSER. She did her medical school training at University of Michigan. She did a residency at CHOP and went on to do her fellowship training at the University of Michigan, where now she runs a very robust program in immunohematology and has the world record for training the most immunohematologists by a very large margin. So Kelly's going to give an introduction on LCH, and then our two debaters, Dr. Olive Eckstein. She received her medical degree from Chicago Medical School at Rosalind Franklin University of Medicine and Science, and then did her residency pediatrics at Children's Hospital Boston. Following her residency, worked as a hospitalist in bone marrow transplant at Cincinnati, and now she's an assistant professor at Baylor, and has a lot of important leadership positions in LCH, including the study chair of LCH Reason, which is a phase 3 multi-site clinical trial for upfront treatment of LCH. She's the study vice chair of Nacho Cometinib. I get that one? And which is a phase 2 multi-site clinical trial for histiocyte disorder, and the vice chair for APEC 1621E, which is a phase 2 subprotocol of the Children's Oncology Group pediatric match trial. Her opponent today is Dr. Jenny Blaze. So she's an assistant professor at the University of Michigan in pediatric hemonc. She did her medical school training at St. Louis University of Medicine and did her pediatric residency and fellowship training at the University of Michigan, and is one of the prized trainees under Dr. Walkovich for sure. She does a lot of great things for NYSER, but she has particular research interests in inborn errors of immunity, and specifically the malignancy risk associated with specific IEI disorders. So Kelly, do you want to start with the introduction?
Great. Thank you. So my role, because both of the debates this year are in what could be considered a little more niche diseases, we wanted to make sure that everyone had a context to understand the more global question. And while the question is more specific, the big question is really applicable across a lot of IAI that we see. And so those are our disclosures, or really mine. And we have just a few objectives. One, we want to share the history of Langerhans cell histiocytosis briefly because it's relevant to the therapeutic evolution that has happened. We want to highlight the complexity of the disease involvement because that drives a lot of our decision making and actually raises a lot of questions on how intensive therapy should be for some patients. And then, of course, I'll leave the fun part to Jenny and Olive, but they get to debate the actual treatment options. So many of you may recognize the image there on the right of the screen. Tennis rackets, Burbeck granules, step 3 coming back to you, LCH, and that might be where your knowledge ends, tennis racket, LCH. However, this is now classified as a neoplastic histiocytic disorder. It affects neonates through adults, although more commonly in children. It was first described in the 1900s after Paul Langerhans utilized a special gold colleague technique to describe tiny populations of epidermal cells called Langerhans cells. Now, interestingly, he got that right, but he thought they were nerves. And so much of the initial therapy was misdirected. And it wasn't really until the 1970s that these tiny population of cells were actually classified as dendritic cells, and not until relatively recently that we understood the derivation of these dendritic cells to be myeloid in origin. And if we think about LCH, those of us who treat it on a regular basis, it's a messy disease. It can affect a lot of different organ systems, most commonly bone and skin. However, it can get the central nervous system, it can get the lungs, it can get the bone marrow, it can get lymph nodes, spleen, liver. And you can see in this diagram, and I think Olive will show it to you again a little later, just the extensiveness of disease also varies. Some patients have only skin disease, maybe one tiny nodule that you're not really sure why anyone even biopsied it, but it came back and it's LCH. Some people only have a single bony lesion that's found either because there's a bump or because there's a fracture at the site on imaging. Some of those you literally just scoop out and that's the end of the therapy. And then other patients, either neonates or adults, can have disease that's multi-system that really can be very aggressive and requires an aggressive treatment approach and response. Now, the big step in understanding LCH came when there was the breakthrough in understanding of how frequently there is a molecular somatically acquired defect in BRAF or MEK. And I think this will play a big role in the debate since we're going to talk about systemic chemotherapy, which historically was the backbone for LCH, as well as now the new targeted therapies. And depending on the paper that you read and sort of the era of the population, it looks like 60+% of patients with LCH have a BRAF variant or a downstream or associated variant. And so because there are so many patient populations that we could think about with an LCH, we decided that we'd go with one of the middle of the road ones in terms of severity. So you have a 6-year-old boy with multifocal bone disease. What do you do? For those of you who don't treat, this usually mandates some form of systemic therapies across the line. And so I'd like to come up, Olive, you're going first, right? Systemic or targeted therapy. So, ta-da!
Generalized format for both of these debates is the two debaters will fight it out, and then there'll be kind of a Q&A session at the end of each one if one is still standing. So Dr. Eckstein, please go ahead.
Okay, perfect. All right, great. Here. What do I do? How do I- Does it click? Just push it down. Okay, great. All right, so I'm pro chemotherapy, so I'm gonna convince you of why that is. And I have to give you a little bit more background because I'm guessing most of you don't treat LCH, but it's actually a really interesting disorder. And I love that it's kind of still a really like a not well understood disorder. Only really in the last 10 years have we made a lot of like scientific progress understanding it. So I want to point out these kids over here. So the first one, A, has a single bony lesion. And was mentioned already by Kelly, you can just scoop it out and never comes back. And we're going to tell you why we think that is. And then B is that kind of like that 6-year-old boy who has the multifocal bony disease. You can see all these little black spots on the bones down on his legs, and so in his ribs. And so that patient has just what we call single system multifocal bone. And then Mr. C is our high risk multi-system involved. He's got liver, bone marrow, spleen, which is our high risk organs. And we'll see what happens when we treat them with inhibitors versus chemotherapy. So the kind of over the last few years, this hypothesis has been circulating in multiple LCH papers that the extent of disease where you see the LCH, since it's such a weird thing, it can happen in bone, skin, pituitary, liver, spleen, all this stuff, has to do with where that cell origin came from. So where that LCH, where that mutation happened. So for these low risk, if you look at the bottom row, the low, that's the neonatal, but the low risk LCH single lesion, that the scoop out the little bone, probably that mutation occurred like well into cell differentiation, right? So myeloid neoplasia, well down into a mature myeloid cell that was in the actual bone, just in that humerus bone. And then it had a little mutation, you scoop it out, it never comes back because it's just in that one site. But if you have a multifocal single system, we think that mutation occurs a little bit earlier in stem cell kind of differentiation, such that you have the ability, maybe you get a bony kind of stem cell, right? You have a bone stem cells, now you can set up shop and have LCH in lots of different bones. Or you get it at a really early precursor in the bone marrow, and now you set up shop in those high-risk organs, the hematopoietic organs, liver, spleen, bone marrow, right? So if you think about it that way, I think it's like a really important framework to think about how we use chemotherapy versus targeted inhibitors and why they may work for just certain subsets of these patients. So we'll talk about that. And then the bottom one, we can skip the neonatal one. But okay, so principles of LCH treatment. So the principles, since most of you don't treat it, is that single lesion can almost always be cured by a biopsy curettage alone. So you just, because it's that differentiated kind of focal localized bone lesion, right? It doesn't happen. It's not a circulating thing that's occurring where you can keep setting up shop over and over. So you can just scoop it out. Even just a biopsy itself can start the process of healing very quickly. Very rarely do we have to go back and do anything with it. So CNS risk single lesion. So there's a thing called CNS risk where you have the risk for pituitary disease and neurodegenerative disease. We do generally treat those patients with some type of systemic therapy because we're trying to decrease the risk of developing those issues in the future. So those are the only ones where we have a single lesion where we do actually use treatment. And then any multi-site, like multifocal bone or multi-system should always be treated with systemic therapy. So, it's driven by abnormal MAPK pathway activation. So this has kind of been another paradigm shift for us over the last several years, and where the vast majority of patients we're able to identify somewhere along that pathway that you have this abnormal activation. The other things that have been really interesting is that we are able to start using biomarkers correlating with the disease activity and phenotype. So just reminding of that kind of hypothesis of where the sites of disease and kind of where the cell is coming from, we have looked at basically prospectively trying to determine the sensitivity specificity of circulating cells that have the LCH, that common BRAF V600E mutation, and then look at disease risk category activity and then risk of recurrence, and as well eventually development of neurodegenerative disease. So you can see here, or Mr. A down here, that single lesion, when we looked at circulating peripheral blood cells that harbored the BRAF mutation, none of them had it. So that kind of goes along with that hypothesis that it's just a focal kind of thing where you're not going to get it. You're not going to have a risk of having things happen again. In the low risk but multifocal bone patients, so that's the 6-year-old that Kelly presented, there was a smattering of them who had circulating BRAF. And we know now that those are the ones who have the highest risk of recurrence. And then a bunch of them that didn't. And then in the multi-system high-risk patients, they all had circulating BRAF, right? And so that shows you that they have this population that's circulating around, it continues to set up shop. And so to think about is, what do inhibitors do to that versus chemotherapy? Foreshadow. So why does vinblastine prednisone? I know Kelly's gonna talk about vinblastine and prednisone, that has been the traditional mainstay chemotherapy of, for LCH for many, many years. And that was, again, just based on this thinking it was an inflammatory process and not necessarily a neoplastic process, but really may be, effective at the LCH lesion itself. There is a lot of inflammation that occurs around it. There's a lot of, cytokine stuff happening, but, prednisone, great. It makes everything look a lot better for a while, but really there's still quite a high risk of relapse and recurrence. And so cytarabine has been used for myeloid disorders like acute myeloid leukemia, classically. And so it really has much better effect on myeloid cells. You don't use vinblastine in AML, right? You don't use, that's not something, you don't use vincristine or vinblastine in AML. So it targets the underlying myeloid clone. And so the goal is to eradicate that, right? Because if you don't get rid of that underlying clone, you're going to keep setting up shop, or you can't just scoop it out. So this is the hypothesis that you have to get rid of that clone in order to cure a patient permanently, which is their goal. And so cytotoxic chemotherapy, cytarabine, clofarabine, vinblastine, if you want to call it that, really getting at that clone. And now we have MAPK pathway inhibitors. So what can they do for us? And probably we'll talk about combination in the future too. So can we improve therapy for LCH using myeloid-specific cytotoxic chemotherapy? Lewis Carroll, can't go back to yesterday, he's a different person then. So vinblastine pred, probably old news in our mind, at least in terms of toxicity profile. It is much, much more difficult to tolerate than cytarabine. So this is my trial, the LCH Reason phase 3 trial at multiple sites where we're randomizing to vinblastine prednisone versus cytarabine for upfront treatment of LCH and looking at all those biomarkers along the way and learning a lot more than I think some of the older studies have done with those things. So this is basically what we do. We stratify patients by if they have risk organ involvement and if they have CNS risk disease. And then once we have them separated out, we randomize from those groups. So I'll give you some more background rationale. So then clofarabine, I'm going to bring this up as salvage therapy, even though what the debate is about upfront therapy. But just to show you that salvage therapy with chemotherapy is actually really good. And we have really, really good results with clofarabine, and is another myeloid active, right? They use it for relapsed AML. Historically, that's where it's been used. We used it at half the dose that we use for relapsed AML, and it's excellent. It's been approved for many years. We have a lot of, toxicity and long-term data on it. And basically has really had a great effect on patients who have recurrent LCH. Okay, so clofarabine, this is one of the earlier studies that looked at clofarabine as salvage therapy. Again, these are patients who already had difficult to treat disease, and overall survival and progression-free survival much, much better than our vinblastine pred that Kelly's going to show you. And then looking at, this is from a clofarabine study that we recently published. If you actually look at circulating tumor DNA with the BRAF V600E mutation, can it be used as a marker for minimal residual disease, right? It's that circulating clone that's kind of a representation of that. And if we look at all the patients who were treated with clofarabine over time from pre-therapy to post-therapy, if they got to a CR, they all went to 0. And their BRAF V600E. So I use this as part of like my decisions in how long I treat patients for, and for monitoring afterwards. I think there's still a lot we don't know about it because we do have patients who have a small number of it circulating around and nothing seems to happen to them over years, but it's very nerve-wracking for parents. It's not working. Did it go? Did it run out? I can't get it to go. Okay, so then this is not published yet, but hopefully in the next couple months. And so this, we had sort of done a smaller group, but now looked at a larger group of our patients, retrospectively though, looking at recurrence probability. And so if you look at just BRAF V600E and wild type, that's been published a few times just in the tissue. Kind of maybe there's a little bit, not really a significant difference between the two. If you look at different studies, some say it is, some say it isn't. But if you look at the patients who are 600E positive in their tissue, and then you look at whether or not they have circulating mutations, you can see that the patients who are the BRAF V600E in red had a much, much higher recurrence rate, right? A much, much higher risk of recurrence. And if the other kids got to, once they stabilized after a few years, they didn't really have it come back. Okay, so now we've also published combination therapy, just to give you a prelude. And so patients using chemotherapy plus inhibitors for patients who relapsed in a bunch of different ways. And we've had some nice responses to that as well. Not going. Okay, so pro-targeted therapy, and then have rebuttal slides.
So, as I mentioned, I'm Jenny Blaze. I think the agenda still says that Dr. Ashish Kumar is going to be here and he uses the BRAF and MEK inhibitor much more frequently. So I'm not him, and I will try to kind of represent some of his data and some of his viewpoints as well. Oh, my mic is not, sorry.
All right. So in general, chemotherapy versus targeted therapy is newer, so therefore it's better, correct? So when you look back at like the treatment of cancer, the first things that were done back in 3000 BC were surgical treatments. So that's super outdated. And then Marie Curie in 1890s brought about radiotherapy. So that was kind of the radiation therapy was the next thing that was used to treat tumors. And then chemotherapy came about in the 1940s during the World War II, started being used. And then the first official targeted therapies were in the 1980s, and then they have come a long way since then. And then really in the last decade or so, more of the immune therapies started. So the first targeted therapy was tamoxifen, which is a hormone-based therapy. It was used to treat breast cancer. That was in the 1980s. The first FDA-approved non-hormone targeted therapy was trastuzumab, which is a HER2 inhibitor, also used to treat metastatic breast cancer. And then I think most of you guys know, that was in 1998, that was FDA approved. And then in 2001, Gleevec or imatinib was approved to treat Philadelphia positive leukemias. So, and then since then it's come a long way. And this is just another article just saying how wonderful targeted therapies are. And then, so traditional chemo for LCH is not great. The LCH3 study showed that there was very high relapse rates. So for multi-system risk organ positive LCH, there was a 60% relapse rate, which is huge. And then even for multi-system risk organ negative, there's still over 30% relapse rate. And there's a lot of side effects from chemotherapy. So you go through all of that chemo, you have all of those side effects, and you still are very likely to relapse. So what's the point? So some of the main downfalls of chemo is you need a central line to administer chemotherapy. That's not great. That has a lot of infection risk, just the central line alone. And then there's very high toxicity, and this is just grade 3 or 4 toxicity in the LCH3 study. And there's anywhere from 30 to 46%, just depending upon if you were on the arm with methotrexate added. The most common side effects of chemotherapy are infections and then blood cytopenias, as well as hepatotoxicity. I think Kelly mentioned this a little bit already, but LCH does have this great target in BRAF. So 60% of patients with LCH have a BRAF V600E mutation. However, the remainder of them, a lot of them also have another kind of mutation in the MAP kinase pathway, as you can see here. So that makes it a great pathway to target. And I'm not going to go through this in general, but essentially those mutations in the MAP kinase pathway allow the LCH cells to kind of promote survival of them and kind of set up shop and accumulate in the tissues. So BRAF and MEK inhibitors, they were first developed actually for the treatment of metastatic melanoma. So the very first one that was FDA approved was just in 2011, so not too long ago, and it was vermorafenib, which was FDA approved BRAF inhibitor for metastatic melanoma, and that was followed just 2 years later by dabrafenib, which was FDA approved in 2013. They're competitive inhibitors for the active conformation of BRAF. Dabrafenib is a little bit more selective than vermorafenib, and that one's used more commonly in LCH. And then MEK inhibitors came about or were FDA approved in 2013 with trametinib was the first one to be approved. And it is a reversible, highly selective allosteric inhibitor of MEK1 and MEK2. And you can just see kind of on the right side, just reminding you of that MAP kinase pathway. And so even if you have a BRAF variant, you can either use a BRAF inhibitor, or you can just go one step downstream to a MEK inhibitor, and it should still shut down the same pathway. So they're used very commonly in other diseases, and the most common is metastatic melanoma. That's what they were FDA approved for. And when they monotherapy for BRAF first started, they had a great overall response rate, about 50% compared to placebo of 5 to 6%. And then the addition of adding trametinib to dabrafenib led to even better improvement. And then it's also used in a lot of low-grade gliomas and NF1 and then other CNS tumors that have the same BRAF variants. So it was first used for LCH in relapse refractory cases, which is how a lot of medications and new medications are first started in the relapse refractory setting. And this is just some phase 1 and 2 clinical trial data from either using dabrafenib monotherapy, so BRAF monotherapy, or the combination treatment with trametinib. You can't really see this in detail, but basically the dark blue are patients, these are individual patients. The dark blue are patients that had complete response. The light blue had decreased, so some partial response, and then yellow were basically stable disease. So all the patients had some kind of either stable disease or complete response, and this was in LCH. So then Dr. Kumar has used this in his patients for upfront LCH treatment. He's at Cincinnati Children's, and so he's using it for BRAF and MEK inhibitors and LCH and then other histiocytic disorders, which I won't talk too much about those, but JXG and Rosy-Dorfman are kind of similar pathway. And so this example here, so this is one of his patients. On the left is up front. So this is a 20-month-old with LCH, and it is BRAF V600E positive on biopsy. And you can see on the PET scan on the left how extensive disease is. It's multi-system. It's clearly in the bone marrow, in that massive spleen that you see there. And then this is the one on the right is a PET scan just 8 weeks later using trametinib alone. So clearly had a great response in this situation. This would be a multi-system high-risk organ patient. And this is the overall data of these upfront pediatric patients. And so there's 18 patients in this retrospective cohort study, and 72% of them had no active disease while being treated with one of the 2 inhibitors. And then another one had no active disease, but just commented that still had the DI present that was already present at the beginning of therapy. And then the rest were either improved or stable disease. And then on the right is just a summary of the types of patients that were included in this group. Most of them were LCH, but there was a couple of juvenile xanthogranuloma patients on there. 60% had the BRAF V600E variant, which is similar to what we see in general LCH. Another 17% had another kind of BRAF variant, and some were unknown or didn't have any kind of variant. And then these were the disease classifications. So he did have on this retrospective cohort, he included some patients that just had like an isolated CNS lesion, but they were pituitary, some that were single system, but multifocal bone, and even some unifocal bone, but had a good amount that were also multi-system. And this was a side effect profile, so super low side effects. This is just in specifically this group of pediatric patients that had upfront treatment with either dabrafenib or trametinib. And you can see very low side effects overall, like 67% said they had no side effects, which there's no way that 67% of patients with chemo are going to tell you they have no side effects. Like they're going to report something. And use most commonly it's rash, and that typically gets better as you're on it for a little longer, and it's kind of like a dry skin that can go away with time or with dose reduction. Only one of the patients of 18 actually stopped the therapy due to side effects, and a couple of them did dose reduce a little bit, but he still saw good response even with dose reduction. Just other notes that there was one, there was some patients that had maybe pre-existing DI, but no one actually developed DI or cirrhosis or any kind of neurodegenerative LCH while they were on treatment. And then he didn't see any skin cancers, which you can get squamous cell carcinoma risk with long-term use of MEK inhibitors, and that's seen in adults. But just of note, this was about 3 years of follow-up average. So overall, the advantages is one, it's an oral therapy. And so it used to be all pills, but actually they could be crushed and dissolved in water and given even to the youngest of pediatric patients. But now they actually exist as liquid formulations. So they're very easy to administer to pediatric patients. You don't need a central line. You don't need to come in to get your therapy to an infusion center. So if you live far away from a big pediatric center, that's okay. Minimal side effect profile, and then excellent response is upfront therapy. And I could just stay.
Excellent. Great. All right. Thank you. All right. So I wanted to point out we should begin with the end in mind because they do look good. They have nice responses, right? But again, the goal, if you're comparing responses, that's not what we're showing from the LCH3 trial or the chemo trials. We're showing like the relapse rate, right? And so that's what the current studies kind of gloss over and ignore. So I just wanted to put up that little thing. Would you tell me please which way out I'll go from here? It depends a good deal on where you want to get to, right? And what we want to get to is a cure and having a durable response, right? That patients don't have to keep worrying about their LCH or having risk for things happening again. Okay, so here's my crystal ball. I'm going to tell you which one it is. So can MAPK inhibition alone cure LCH? So it definitely demonstrated clinical responses in 86%. We did a retrospective study on 21 patients of heavily pretreated patients who had relapsed refractory LCH. They had a response, but they didn't get to a complete response. That was only in 19%. And they had persistence of those BRAF V600E circulating cells if they had them to begin with. So that suggests that it's not cytotoxic. We know it doesn't work the way that cytotoxic chemotherapy does. And so maybe we need to do combined chemotherapy and MAPKI. So maybe I'll concede that. But I do want to say, like, I like to think of MAPKI and chemo as like, if you think of bacteriostatic, bactericidal antibiotics, it's sort of like MAPKI is like histostatic and like chemo is histocidal, right? It like gets rid of and kills off that. So just like that. So this was our Natural Libre study. The survival rate was great. It didn't have anything to do with treatment-related mortality. One was like an HLH, secondary HLH, but really, didn't have, had some nice, good responses, right? This is a nice example. I will concede that it can work, right? With vemurafenib in some classic neurodegenerative looking stuff in the cerebellum. Also on PET scan after 7 months. But now you look at progression-free survival, right? And now it's even worse, right? So the progression-free survival was 35% in the patients that we looked at retrospectively who were treated with inhibitors. And so that's just way, way not what it should be, right? And clofarabine, like I showed you before, had excellent, right, and durable responses. So if you're getting to the point of refractory salvage therapy, and again, maybe we need to use clofarabine for certain patients up front. I think that's one of the questions. But if you're getting to that point, do you really want to give them something again that's going to get something this far along? Or up front, do you want to give them something that's not going to get rid of it the way that other things can? So we looked at looking at the circulating tumor cell burden. Dr. Kumar's paper did not publish that. He looked at some of it, but didn't show like the kind of longitudinal look at what the cells were doing. And you can see they're all over the place, right? They didn't have that nice slow decrease to zero, right? They were all over and they stayed there for many, many years. So then I said, what does ChatGPT say? It's my new favorite thing. Thought I could make you laugh at that. So what does ChatGPT say? Can target inhibitors cure cancer? Is there like any example where a target inhibitor alone can cure cancer? And you can come up with it. It's very, very, very few examples out there, right? I'm looking at my farm friends, but like, I don't think there are any. And so ChatGPT says, yeah, they work, but cancer is complex, can be resistant to treatments that really can sometimes blah, 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 right? Like very, and then I asked, do MAPK inhibitors cure cancer? And it can be effective, right? But many patients may experience cerebral sounds, but resistance can return. So they're generally not considered cures. So nitty gritty, the only kind of critique I wanted to point out with Dr. Kumar's publication is that there were some very if you look really closely in your looking glass, depending on how you look at it, seems great. But all of the multisystem LCH patients, every single one of them, and he said that, who stopped MAPKI inhibitors experienced a relapse, no matter how long they were on it, even patients who were on it for longer. There were 3 patients, this is for upfront therapy, for 3 patients who had single system multifocal bone, so that 6-year-old patient, 2 of those 3 relapse after discontinuing their MAPKI. And that third one really hasn't been followed for that long. I think it was only 11 months of following, right? And we know they can recur up to 5 years later. So that's not very promising. But the patients who remained in remission after stopping their MAPKI had single bone lesions, right? We don't even have to treat them. The only ones we treated that we talked about were the CNS risk lesions, right? Just to try to prevent neurodegeneration and these issues long-term. But that hasn't been proven that that's even going to work for that, right? So is there a future for MAPKI? I think there is. It's a great bridge if you have a patient who's really sick. I have a patient who just has randomly got active TB. I have no idea, still don't know how, these 2. And so I'm using an inhibitor to try to decrease like my kind of neutrophil T cell effects until he's gotten enough, you know, a couple months of really good TB treatment, although we have interaction issues. But, you know, there's a role for it, either combination as a bridge, kind of like how you use blinatumomab if you have a really sick leukemia patient. But I think to get to a cure, we still need that chemo somewhere in there, somewhere along the way. Stay up here with you.
Thank you so much. So as Olive mentioned, the majority of the patients that had multi-system LCH did have detectable circulating BRAF V600E cells by histiotrack even years after therapy initiation. So it's clear that it's more of a histiostatic kind of effect in those kind of patients, and there must be some low level of disease kind of hanging out. And the ones that kind of stopped their therapy did experience recurrence of disease, but and the upfront therapy, all the ones that then just restarted that same therapy were able to get back to no active disease. And we know with chemo, if you relapse after cytarabine, you are not just going to restart the same medication. We always say we have to do something new now, and we're going to run out of new things to do. This, you can just restart the exact same medicine. So seems a lot simpler. And then, and that's just kind of, yeah, they might not fully eradicate disease in these multi-system patients with LCH, but they could at least induce a clinical or silent remission, which might be enough for some of the patients. So really the summary, they could be used as upfront therapy for LCH, and they do have some efficacy, but really to truly assess the safety and efficacy profile, we really need clinical trials. Especially clinical trials in our pediatric patients would be amazing since they have a long lifespan, and depending upon how long they have to be on these inhibitors, we really need to know the safety profile. So this is just a plug that we just need this group to be included in upcoming clinical trials. And until then, we're really just have to present the different options to our patients and their families and the pros and cons of each option, and help do just shared decision-making with our patients to see kind of what are the goals for each patient on their therapy. And that's all I have. Yes, Sean. I don't know if there's anyone.
So both extremely well argued. I was curious, you know, just because you guys did bring up imatinib, right? So one of the issues with a lot of the, is it on? Oh, okay. A lot of the issues with the first generation TKIs, of course, as you know, is that predictably within 5 years, you would get some kind of resistance clone like T315I. So could you guys both comment? I mean, since you're both are, you know, some kind of monotherapy, could you comment on the development or selection for potentially resistant subclones sweeping to dominance and then having to treat yet another form of LCH?
I could start. I mean, I know Dr. Kumar has told me when I had a patient who I thought was maybe relapsing while they're actually on trametinib, he said he had seen 0 patients progress or relapse while they're still taking their TK or while they're still taking their MEK inhibitor, but you might have had different experience. So therefore no resistance that he's noticed.
But again, a lot of those are those like single lesion patients, right? Not the multi-system patients. So we have seen it in our retrospective natural libre study that we published, but we did show that, and then they were switched to other things. The other thing that, you know, if you look at the melanoma world, you will see it there, right? You will see that those patients eventually progress, obviously, right? And so I think the other thing that's really interesting is from the melanoma world, the BRAF inhibitors, when they're used alone as monotherapy, those actually cause paradoxical, the kind of older generation ones cause paradoxical activation of the BRAF pathway. So that was one of the mechanisms by which they thought that developed. So when you combine it with a MEK inhibitor, they actually had better outcomes, and even better than, except they never compared it to MEK monotherapy. Anyway, that's another story. But when they combined it, BRAF and MEK inhibitor, they overcame that resistance. But I think eventually they're going to have they have the same issues on the melanoma studies. I can't see why it would be any different.
I'm missing blood loss and hair pulling, but curious in both of your approaches, the impact on fertility and particularly safety of getting pregnant on the BRAF inhibitor, MEK inhibitor.
Okay, so I mean, nobody knows. So we just, our study for NACHO-COBI, which is a MEK inhibitor study for phase 2, patients aren't supposed to use birth control and all that stuff, right? And supposed to wait 3 months after till there's probably some teratogenicity. It hasn't been around long enough for us to say. Fertility wise, though, from a chemotherapy standpoint, none of these chemotherapies are known to have it. They're not alkylating agents. They're not known to have any impact on fertility long term. And clofarabine's been around, for 20 years now. So I feel confident saying that for those patients. And so I think there's no hair loss in ours either, by the way. Just wanted to point that out. It is not chemotherapy where the kid looks like it. I mean, my kids go to school, clofarabine, they can come and go to school if they do okay with it, right? So even there's no hair loss and also no fertility issues, no long-term kind of issues that we know about. And again, been around for a long time. And then the other one I wanted to say about clofarabine is, I'll remember in a second. Okay. Oh, yeah. Okay. Questions?
I'm just curious, so if you were going to use the combination for example?
Yeah.
Dr. Kumar doesn't usually, most of the time it's one or the other. Yeah. And now he mostly uses MEK inhibitors.
A lot of people I would say that's been more common now. And there have been patients who were initially on BRAF inhibitors and then they progressed, then people would put them on a MEK inhibitor. The MEK inhibitors alone, I think they seem to work in a lot of cases, but maybe you could get a longer duration of not having resistance if you'd use both. But then those are only really going to work in patients who have BRAF mutations, which is only like subset. So that's one thing I didn't point out though, is that there's 40% of patients where we can't follow peripheral blood for these things, right? We don't have that marker. We don't know what's going on with them. And so we don't have that to help us kind of guide our decisions.
So I agree that I think combination is probably the best way to go, but I really debate with myself which way to do that combination therapy. How do or would you do it?
So we did publish something on that recently on like a small group of patients that we've done in many different ways. And I don't think I have a right answer yet. I do think, so we've had patients, I've had a histiocytic sarcoma patient, 2 histiocytic sarcoma patients. Interestingly, one started on cobimetinib, MEK inhibitor, progressed, got added with clofarabine to the COBI and has a great durable response. The other one started on clofarabine because they're like, obviously we just need clofarabine, and had a good response, kind of stopped having good response, added COBI, and he's doing great now too. He actually had leukemia first, got that during his maintenance therapy. So, I think there's maybe together synergy. So we do like a week, we do 5 days of clofarabine, 21 days of cobimetinib in a 1-month cycle is kind of our typical kind of concurrent combination. But I do think that maybe in the future, especially when kids are really, really sick when they first come in, I kind of like the idea of like an induction with inhibitors for like 2 to 3 months where we expect to see a really good response at first, kind of lower the burden, the inflammation, all the kind of major toxicities of the kids got cytopenias and liver problems, all that stuff, and then give them kind of a consolidation with cytotoxic chemo. So I think there's a couple of different ways they could go. I don't know what the right one is yet. Yeah.
Okay, I think that's a great way to end because it sounds like you both won
Yeah.
with that combination. So fantastic talk for a very complex disease. So thank you very much. We're going to move on to our second debate. So again, same format as before. Dr. Irem Eldem is going to do her introduction. So she's an assistant professor in pediatric hematology oncology at Washington University. She received her medical degree from Hacettepe University School of Medicine and did her pediatric residency at Ankara University School of Medicine, and then in the United States at Texas Tech University. She just recently completed her fellowship and has great things in the past and in the future for her in pediatric hemonc at Washington University, and is now there specializing in pediatric hematology. Our two debaters will be Dr. Beth Thalen and Sarah Kaviani. Dr. Thalen is a physician scientist trained in both adult and pediatric infectious disease. She joined the faculty in pediatrics at the University of Minnesota in 2020 and is developing a translational research program focused on molecular epidemiology and viral pathogenesis of human respiratory viral infections, including influenza and RSV. She has many interests in clinical immunology, as we all know here, in the role that host genetic variation plays in the response to infectious diseases and the global burden of respiratory infections. Sarah Kaviani, she received her medical degree from the Chicago College of Osteopathic Medicine at Midwestern University. She did her residency training at Advocate Children's Hospital and Pediatric Hematology Oncology Fellowship at Vanderbilt University. At Vanderbilt, she worked in the lab of Jeff Rathmill to better understand the pathobiology of inborn errors of immunity, including STAT1 gain of function and FOXN1 insufficiency. She is currently an assistant professor of pediatric hematopoietic cell transplantation here at the University of Chicago, where she specializes in transplant of patients with rare blood and immune disorders. Okay.
Hello, everyone. I will be talking the introduction part of this session, and Devon will move forward with two different aspects of this very interesting disorder, complement system disorder, paroxysmal nocturnal hemoglobinuria. We already listened beautiful talks yesterday from academia and pharmaceutical about the PNH. I will be more emphasizing the hemolysis aspects and how we can approach those patients to control the disease and or to cure the disease. So here, Sorry, I would like to start with the complement system. Complement, as it comes with the name, it complements the humoral immunity in our body, which is the activity of antibodies to kill the cells and the microbes. In the complement system here, you could see on the right-hand side that it could be activated at 3 different pathways. The alternative pathway, which is the major responsible pathway in the PNH, classical pathway that is dependent on antibody antigen complex that is formed on the microbe itself, and the lectin pathway that depends on the mannose binding lectin. So the goal here is the early step is to activate the C3 convertase that will form from C3 molecule, C3A and C3B. And the complement system, if you're seeing A, it stands for the anaphylotoxin, so which means that it will induce inflammation. And if you're seeing B, it goes with more opsonization on forming the membrane attack complex at the end of the whole complement system, which is quite powerful to kill the microbes in the cells. And here, the major mechanism about the PNH is it is the absence of regulatory components of the complement system, especially the alternative pathway, both on the early phase and at the terminal phase. CD55 that blocks the C3b convertase, and then CD59 that blocks the MAC formation. But unfortunately, those PNH patients acquire absence of CD55 and CD59. So historically, this is a very rare 1 in a million disease, and it is acquired. The reason it is acquired, because it's not life compatible if you have total absence of the PIGA protein that I will explain in a second. That is the glycosyl phosphatidylinositol anchor protein that responsible for the attachment of CD59 and 59 on top of the cells. And those patients, because they don't exist, and even embryologically it is lethal, this disease is an acquired form. It was described in 1880, but it took about 100 years to develop the complement inhibitors and actually explaining the mechanism and then the complement inhibitors that we're using to help the patients. And here you can see 1980s, the discovery of the missing GPI anchored proteins were discovered. And then eventually around 2000s, the FDA approved that I will show you summarize in a second, the complement inhibitors now we use to control the disease. However, around the world, there are countries who still don't access to those complement inhibitors and sometimes do not have the compatible, suitable donor, and who has unfortunately die because of complications of disease, which is the major one is thrombosis. And that's why it's really important for us to spread those treatment options. One particular important thing here is normally healthy individuals also has PNH clones. So it varies, but like about 1,000, 3 in 1,000 cells, you can see in the bone marrow of those PNH clones, and it doesn't cause anything because they don't gain the clonality. So the problem here in PNH is there is an increased clonality of those acquired PGA mutations in the hematopoietic stem cells. And here they're explaining the symptoms according to mechanism, which we call it tick over phenomena. Normally in our body, C3 is like ideally, like subtly activated already. And in those PNH patients, because of this activation, there is ongoing chronic hemolysis. So this is one thing that we address with the complement inhibitors. And there are some outbursts through the amplification mechanism that's such as a stress, inflammation, surgery, infection. It will cause more outbursts on top of the baseline continuous hemolysis. And that is called as the paroxysm. That's what patients severely experience through. And when we move forward with the complement inhibitors, one thing I would like to tell you here is because if we inhibit only the C5, which is eculizumab and revoluzumab, the problem here we end up with is C3b will be already formed. And when it is formed, it will already opsonize the cells. That being said, there will still be ongoing extravascular hemolysis within the liver and the spleen. And that's why we need maybe dual therapy, which we'll talk about. And as these patients still has ongoing hemolytic symptoms and transfusion dependence. Clinical manifestations, as we already know, hemolytic anemia is the landmark. And when there is hemolysis, there will be always thrombogenicity. And here is like, think of a sickle cell disease, but acquired form. There is always like increased viscosity, inflammation driven by the complement activation, platelet reactivity, and also the tissue factor pathway inhibitor, which is the TFPI beta, that inhibits the clotting factor activation through the tissue factor pathway, is a GPI anchored molecule. And that's also missing here, which increases extra thrombosis. There is always bone marrow failure component. It could be very minimal, or it could be very more extreme that we see in the children. And as a pediatric, we don't follow the classical PNH that much often, but we do see with the acquired aplastic anemia that because the bone marrow failure goes hand by hand with the development of those PNH clones. And interestingly, those patients, because of the hemoglobin, free hemoglobin within the system with hemolysis, the nitric oxide will be depleted, which will cause dystonia. So that's why they have those pain issues and like erectile dysfunction and pulmonary hypertension and chronic kidney disease because of the vasoconstriction and the hypoxia. And this is what I was telling. And here the clone number is really important. And what we are seeing is if you have less than 30% of the PNH granulocyte clone, you should be okay. Like you shouldn't be seeing clinical symptoms of PNH. So the clonality here, the quantity is really important. In classical PNH, there's more than 50% of granulocyte clones. That makes the disease very detrimental. And that's where you need the complement inhibitors to improve the outcomes, or transplant that we will discuss. But the other acquired aplastic anemia patients, so it should be it shouldn't be inherited bone marrow failure. They have more bone marrow failure, but they will have less classical PNH symptoms. So only 1/3 of PNH patients have classical form. In the diagnosis, so we talk a lot about the molecular diagnostic and genetics, but here flow cytometry is the best test to go for. And we should be doing it through the peripheral blood because there is some bone marrow failure component, and we could miss some of the PNH clones if you're doing in a hypoplastic bone marrow. And if you look at the test report, you should be seeing this minimum 2 cell lines. So it shouldn't be only red blood cells. Both red blood cells and white blood cell PNH clones should be reported to get a better assessment. And because the hemolysis, red blood cell PNH clones will disappear. So we should be looking into the granulocytes to get a better assessment. And LDH, reticulocyte, other measures also help to understand the disease severity. Now we will move more fun part, which way to go. So I think we will have a very thorough discussion, but I would like to just remind you what are the medications that control the disease. These are complement inhibitors. And then we have a curative option, which is hematopoietic stem cell transplant. Complement inhibitors are great because in the past, those people used to pass away less than 10 years after diagnosis. Now we're talking about more than 20 years, thanks to complement inhibitors. And the goal here is to control both intravascular and extravascular hemolysis to control the thrombosis. We have wonderful FDA-approved drugs, and they have different, delivery options. The late steps, the terminal pathway, eculizumab, revolizumab, and the final medicine that joined with FDA approval 2 months ago is crovalimab, but they all inhibit the late step. So which means that it will not control the extravascular hemolysis. Those patients, about 10 to 20%, still has ongoing hemolysis and they require transfusion. And that being said, it could be given IV, and revolizumab has it's easier because it's every 8 weeks rather than the eculizumab, so it might be more convenient. Crovalimab, it could be given sub-Q every 4 weeks, approved above 12 years old. And then we have pegcetacoplan because they saw that, okay, there is extravascular hemolysis, let's inhibit the C3 component. But unfortunately, probably because maybe through activation of the other pathways and some still ongoing complement activation, those patients with monotherapy still has ongoing hemolysis, but it's sub-Q and given twice a week. The other 2 new generation medications, danicopan and iptacopan, they are early step inhibitors, and danicopan is an oral medicine. It's a factor D inhibitor. And the beauty of that is it's not affected by acute inflammation because factor D is not an acute phase response protein. So, and it's given orally 3 times a day. And as an add-on therapy, they're having beautiful results. And similarly, iptacopan just approved again, I think last month by FDA. And it works through another factor here, factor B, that helps the alternative pathway activation. And as an add-on therapy, it really decreases the transfusion need. And this is the summary of all of the chronological order of phase 3 clinical trials that started in 2008 with eculizumab, and then revolizumab, And then within the last 2 years, we had a great improvement and success stories that come with the add-on treatments, danicopan, iptacopan, pegcetacoplan, and the final product, curvolumab. Now, I would like to introduce Dr. Beth Thielen and Dr. Sarah Koviani to discuss about those two different treatment options. Thank you.
Thank you for the invitation to have an ID doctor talk about a hematological problem. Just in terms of disclosures, the biggest thing here is I'm an advisory for the meningococcal vaccine, which I will not directly touch on today, but I will touch about the theory. So you just heard all these great things about the targeted therapies. We've got some oral options, we've got longer acting options. So really, I don't need to make the pro argument for those. So I'm really here to talk about the elephant in the room, which is these black box warnings about infection. And so I hope that you will leave today feeling very reassured that these are non-issues, which I don't think you'll hear from my opponent, Dr. Kaviani. She has a far taller order to talk to you about the safety of stem cell transplant. So I want to go back a little bit in time to some of the trials that looked at these drugs, and so I'll go back to eculizumab first. So this is a figure from a paper looking at long-term safety of this drug. And you can see the probability of survival is a straight line at like 100%. This is a great safety profile. We've got fairly minor things like headaches, nasopharyngitis, but I'm sure what you want to hear about is the meningococcal disease. And so that here it is in the figure. Here's the meningococcal sepsis. And there were sort of two cases, and I want to dig into that a little bit more. So one was a serotype B infection that occurred in a patient about a year into transplant. And this patient actually wasn't even vaccinated with our current generations of vaccines. So they had received the quadrivalent vaccine, but they actually had an infection with serotype B. And although this was an issue back when these trials were done, this is no longer an issue, which I'll tell you about. The other case had a serotype Y or W infection, and again, not vaccinated with the appropriate targeted vaccines. So they had a bivalent vaccine, and now they had a quadrivalent conjugate vaccine. So both of these cases could have potentially been prevented by appropriate vaccination. Here's the table summary from a review summarizing the case reports of meningococcal disease. And so there were a total of 9 cases in 8 patients in this review. And so 4 of the 9 cases hadn't been appropriately vaccinated with a vaccine targeted to the infecting strain. And then if you actually delve into the cases that were vaccinated, one of them was using a non-conjugate vaccine, which we really don't use so much in the US anymore. We have conjugated vaccines that improve the immunogenicity. One was heavily immunosuppressed. So this is, we can kind of predict they're probably not going to respond. And I mean, it's unfortunate, but I think we have an explanatory, sort of an alternative explanation. And one had vaccines, but had documented low titers. And I think that is something we can kind of think about is whether we, repeated dosing or things like that in patients that might be less likely to respond. And so this, I want to highlight for folks here, I use the CDC's tables of appropriate vaccinations a lot. And so I just want to highlight there's special tables for immunocompromised patients, and there's specifically a category for asplenia or persistent complement component deficiencies. And so that's, you can see here that the brown is the sort of special indications. And if you follow the lineup, you can see that really patients with complement problems should be getting vaccinated both with this sort of standard sort of quadrivalent pool of antigens as well as a meningococcal B vaccine. And that historically has been really, multiple doses of vaccines. It's sort of a complicated schedule, but there's actually been some innovation in this space that's made it a lot easier to keep our patients up to date. And so just in the last year, the ACIP voted to recommend a pentavalent form of meningococcal vaccine. So that basically combines the antigens for quadrivalent vaccines plus this B serogroup in one product. So it's going to make it easier for everybody in here to get their patients appropriately vaccinated in advance of their therapy. And then I think the epidemiology has really been changing in interesting ways too, which I think has made this probably less of an issue over time. And so what you can see in this graph over time going from 1996 to 2022, there has been a steady decrease in the number of cases of meningococcal disease over time. And some of this corresponds with vaccines and some of it doesn't quite, but the message is clear that this is a less of a disease burden, has become less of a disease burden over time. I mean, if you actually look at the types of serotypes causing disease, you can see probably some of the reason we've had breakthrough disease has been the role of MNB, which we had a vaccine that came up later for that, and it doesn't have the sort of universal age-based recommendation. It only has a sort of risk-based recommendation. And so I think there's been a mismatch in terms of getting recognizing our patients getting appropriately vaccinated based on their risk-based recommendation. And so this has created some gaps that hopefully with more easily administered combined products will be less of an issue. Now, my opponent is probably going to bring up some counter data here and say, well, but what about there's been case reports, just like this case report here, of patients that have non-standard serogroup infections, and in fact, they can cause fatal cases. And I will acknowledge that this is a potential risk, but the numbers are very small. And I think what the historical data has shown is that really most of the disease that's out there can be prevented with our standard serogroups. As an infectious disease doctor, I kind of hate universal prophylaxis. I think that is something that can be talked about for meningococcal disease. And I did just want to raise this little caveat in your minds that we historically have not seen a lot of drug resistance, but there have been some outbreaks lately that have shown both dual resistance in meningococcus to both beta-lactams and ciprofloxacin, or the fluoroquinolone antibiotics. So just something to keep in mind when you have patients coming in potentially with breakthrough symptoms that need urgent therapy, or if you're going to entertain the idea of prophylaxis, just keep in mind that there's been some changes in the epidemiology of resistance lately. So basically, when those first studies came out, we really weren't optimizing our pre-drug protection. And I think what we've seen actually is some trends of improvement as we've come through later generations of studies where we haven't seen those same signals. So these are data from ravulizumab, and they had a couple of deaths in this study, but notably no meningococcal infections were seen. So again, this is an patient population that's probably optimized for protection. And similarly, one of the new add-on agents that we heard about just a few minutes ago also weren't seeing a signal for meningococcal disease. So I think if we really apply appropriate preventative strategies, I think we really can mitigate the safety risks, which again, I put it to Dr. Kaviani to convince us similarly for stem cell transplant. I did want to say just a quick word about pneumococcal disease, because looking at the ACIP table, there is a recommendation for pneumococcal vaccine really in all our immunocompromised patients. And there's also been some changes in the vaccine products available that I think are worth knowing about. So in the last few years, we've seen rollout of both a 15-valent and a 20-valent pneumococcal conjugate vaccine, abbreviated PCV 15 and 20. And so those have added on additional serotypes to what we were using for a number of years prior, which was the PCV 13 vaccine. There's another vaccine that's in the pipeline, this is so-called PCV 21, which is a little bit of a funny product compared to the evolution of prior versions of pneumococcal vaccine. So it's taken out some of the strains that have been in previous vaccines and added in a bunch of others. And I think this figure from the ACIP, this came from a recent ACIP presentation, and it really shows that the PCV 21, when it hopefully when it is available, will fill in some gaps that have existed in strain coverage for previous vaccines. And so it's not perfect compared, there's still some coverage for PCV 20 that PCV 21 does not have, but it really starts to plug some holes in our adult patients in terms of the strain match between what's circulating and what people are protected against. So I think in conclusion, I would like you to take away that the majority of infectious risk in these patients on chronic complement inhibition can be mitigated with current prevention strategies and talking with your friendly local infectious diseases physicians. So with that, I will pass to Dr. Kaviani to give us the pro.
It's intimidating me.
Yeah, I'm just gonna.
Yeah, I kind of like it.
Yeah.
Okay.
I'll sneak around behind you, kind of.
Yeah, okay, I'm here for it. Mine's actually pretty short, and it has nothing to do with the fact that we still use drugs from the 1950s, but it's because transplant's the best. Disclaimers, really, I just want to point out, I'm gonna say sassy things, but don't take it personally, especially my pharma friends. Please don't hate me. Okay, so let's talk about PNH. This looks awful. I mean, guys, come on, like ED, but also marrow failure, all these clots. MI, like, hello, what quality of life are we having here, right? And we want cure, cure, cure. And the only way we can cure is transplant, because we are fixers. At least that's what my therapist tells me, but we are fixers in the transplant world. So we want to cure. And really, I just want to point out, joking aside, the aplastic anemia, the bone marrow failure, all these fancy drugs, they don't do anything for that. And so if you have an empty marrow, like, good luck, you're going to die anyways. So we got to transplant you, right? And I'm going to fix you. Also, I just want to point out a couple really transplant wins. None of the patients who had stable engraftment after transplant had any relapses of their PNH or PNH symptoms. And then there's countries, I know we don't really care about other countries, but there are other countries that don't have eculizumab. So we want to be able to provide treatment options that are available to all, if not most. And insurance. I mean, guys. So you're on like year 5 of complement inhibition, and the insurance company calls you and says, JK, we're not covering. Then what are you going to do? You're going to refer them to me, and they're going to be a hot mess express. So I'd rather, in the words of Scott Canna, like, transplant them 5 years before all that happens. Right, Scott? Yeah. All right. I got a fist bump. All right. And then there are definitely patients that we know are refractory to eculizumab. So transplant, we know what we're doing. Right, Jim? Although Jim Connolly, my mentor, just turned to me and goes, Beth's good. Thanks. It was really like a nice pep talk coming up here. Okay, I don't have that much fancy data because we're transplanters and we don't believe in publishing things because we tell everyone we're perfect. But like, if you close your left eye and you squint really hard, that number is almost at that 1. So almost at 100%. But this is looking at overall survival and then GVH free, failure free survival of patients who are going to transplant. And this was a single center study, but you can see it's still great and probably the best paper I could find. So don't judge me. And then so I know my opponent's going to be like, well, there's not always a match SIB and blah, blah, blah. Look at this. This is haploidentical transplants and outcomes. And again, this time, if you kind of close that left eye and then like squint a little and then put the fingers in front of your right, like those numbers look pretty close and those lines are kind of coming together really nicely. We don't do a bad job. Like, we can do it. Exactly. Who cares, right? Coming from a transplant. Okay. And she didn't bring it up. She taunted me with it on the way to the bathroom earlier. And she's like, well, what about CMV? Okay. So I will say, as much as like we still use cyclophosphamide and busulfan, which legit I Googled and were from 1959. We now have drugs like letermovir, which is probably really the only thing that has been impactful. This is really controversial, but one of the only drugs in the transplant world that has been tremendously impactful in outcomes. And some of the fears of patients with aplastic anemia is post-transplant viral reactivations and death due to CMV largely. So look at this. This is a letermovir study. Looking at patients specifically with aplastic anemia actually after bone marrow transplant. And you can see that, yes, you know, CMV can be an issue, and my graph got cut off at the top, but that blue line is how much CMV we were seeing further out from transplant without letermovir added on as prophylactic CMV medication. And then the red line shows that with letermovir, we're basically eradicating it. So like, stop it, like, not a big deal. We got it. I don't know why they chose to depict it this way, but I kind of liked this picture. So just another way to show you that, look at all that CMV that we used to have to worry about. And now we really don't have to in the era of letermovir. And we have way better drugs to kind of mitigate that risk, as my opponent would say. Okay, if you have ADHD like me, you won't actually read the paper. You'll just take the title and post it on a slide and use it as an arguing point. But like, let me just read it for those of you who can't. Eculizumab's unintentional mayhem. Mayhem. That does not sound good in a patient who's already very inflamed and lots of organs are involved. Okay, I won't tell you the conclusion of the paper, but really, this is all that matters. The title says it all. Okay, and then infections, let's just take a step back. Every life counts. And that poor patient who had breakthrough meningitis also counts. All these bugs that we care about in the transplant world and everyone freaks out about, like Pseudomonas, woo, we have cefepime, but these guys are getting it, right? Not good. The risk for invasive meningococcal infection, that's already so high. And imagine you have like a college age kid you're sending, they don't want to be compliant with vaccines or their daily penicillin. And then as she pointed out, there are definitely vaccine failures. And I will leave you again with the title that she already presented, saying that every patient counts. Like we are a rare disease consortium. Every patient counts. And that's it. Transplant is the only cure. In the words of Hakeem Jeffrey, we broke up with you for a reason. Been there, done that. We ain't going back. Like eculizumab is a thing of the past. Like transplant is the answer. I'm done. Bring it on, Beth.
Yeah. I mean, I think my colleague, I think really didn't take the argument seriously with an abstract title, a title without any content. Really, I think the people here, recognize the evidence when they see it, and I think my data speak for themselves. Yeah,
exactly. And what I was really going to say is, who in this room loves David Frame? Raise your hand. He just talked to us for an entire hour about how we have no idea how to dose any drug in any body ever. So really, we don't actually know what we're doing. And with that, I think transplant is the answer. And we will take any questions. Thanks for listening to us for half an hour.
So I feel awful that I don't know this and I've looked for this. So I guess my first question is, do you check titers after the meningococcal vaccine? And does so often we end up not giving the vaccine right off the bat for a variety of reasons. And I've really worried at times that maybe the complement inhibition actually decreases the efficacy. But it's not one that we often check titers on. So do you know if it affects efficacy, and do you check titers?
So I personally don't check titers. But I did come across in preparing for this some papers. I think they were out of Europe that actually did follow titers, and they have some they put forth some recommendations in there around revaccination periods and checking titers, but I don't know that I haven't seen that come sort of across the board as being universally accepted, and I think it's challenging. I think there's also issues of potentially a payment for doses. And I know when we depart from what ACIP in the US, when we depart from what ACIP has spelled out, it often creates a lot of problems in terms of getting reimbursement for things. So I would say, yes, there's discussion of that in the literature, but I don't exactly know how to operationalize that in a US based practice environment.
Sarah might not be my friend after this. But I will also say in Beth's defense that you do have to use drugs for transplant too. So apparently dosing those is going to be problematic. Actually, Beth, I had a question because you know, with the vaccines and the changing landscape of vaccine use, does that impact the amount and repertoire that people find in IVIG or any kind of IG replacement?
Probably, and I guess that is a really, yeah, that's a tricky question. I mean, we saw it with with COVID, it came up in the most clear where there's like the lead time that it takes before things end up in the IV product. And then I think that it's a really good point. And I haven't seen any studies that specifically quantify that, but I think it's a good thing to be mindful of.
Standard protein-based vaccine like Tdap. We don't have patients get those vaccines if they're on immunoglobulin replacement therapy. But for vaccines that are encapsulated, like meningococcal, strep, or that change every year, like COVID or flu, or are not as widely given, if the patient is able to respond in any way, then we suggest that they get those vaccines. I only check meningococcal vaccines if insurance denies immunoglobulin replacement and I'm looking for crappy titers. Then I check them, and then the titers are crappy, and then insurance will sometimes let me use it. But I don't find that titers are very helpful.
I have a question. So, so I think in general, when you compare, and I'm totally not biased in this statement, where when you look at in the non-malignant disorders, if you look at survival, transplant will never win. Okay. Because obviously even the best transplanter, we're going to lose lives for that. So really when we're talking about efficacy and comparing transplant versus any non-transplant option, it's really looking at other composite endpoints, such as, which is hard in PNH because, you know, as was beautifully said at the beginning, is that there are a lot of manifestations of the disease, which I would imagine some of those aren't, you know, you might be improving survival, but you're probably still living with the disease and having some of those manifestations. So how much do we know about these complement inhibitors of truly causing or creating a disease-free survival? And would that curve be expected to be way below the transplant curve?
Okay, I was only like partly kidding during most of that, but I think that's a really good point. And I think the challenge with an argument like this is the one thing that we know you have to go to transplant for is if they're having bone marrow failure and aplastic anemia. Like it's not really a fair head-to-head argument because you're not going to affect that with your complement inhibition. But in that paper that I actually did read, there are patients who can kind of break through or have disease manifestations on top of that. But I think largely if you're compliant with control, and we all know we use this drug in other transplant settings and monitor PK and all of that, you can get pretty significant improvement in symptoms and hemolysis. I just took a PNH patient. This was like literally coincidental to transplant with the biggest clone, like real PNH, 80% clone across 2 cell lines. And he was 17 and was running track and only presented with a hemoglobin of 4 because his mile time changed and he was so upset. And he had marrow failure. And so we had to take him to transplant, but to stabilize him for transplant and to prevent his clotting risk, because I'm putting central lines in him and, you know, prepping him to get there. And he ended up coincidentally having like a huge undiagnosed ASD and needed cardiac repair. The only way to get him there safely was with eculizumab. And, you know, when we scanned him, it was really interesting. I hypothesized that he was throwing microclots into his lungs because he had these like weird micronodules that were not infectious on bronch BAL, Carius testing, all of that. And he symptomatically improved. And eculizumab, I will say, did decrease his rate of needing transfusions as we were taking him to transplant because he wasn't hemolyzing as quickly. So while we weren't going to correct that compartment completely, at least in my hands, anecdotally, you were able to see some pretty good symptom control, but it's varied across patients, to answer your question directly.
So the PNH patient who doesn't have
Asking Sarah if the PNH patient who doesn't have aplastic anemia should go to transplant. No, but does that mean I lose? Go ahead.
So, you know, one of the slides mentioned that everyone has some low level PNH clones, and certainly at Hopkins, I think almost everyone who has suspected bone marrow failure or aplastic anemia gets screened for PNH clones, and a lot of times they do find some low frequency percentage. What is your threat? Because I was told that there's no real like correlation between the frequency burden and symptomatology. So what is your threshold for treating a patient if you find like
the
a low
$1 million
level?
question, and I'll let you comment too, but there's actually literature to suggest that those low level clones actually make patients more I don't want to say susceptible, but more likely to respond to classical immunosuppression for their aplastic anemia. So like ATGs, like the cyclosporin pathway and not transplant. So I have yet to find a paper, and actually the paper that you was looking at that a little bit earlier. That paper that you posted was probably the most delineated I've seen. I've never been in any sort of situation where we say like 30% is that number outside of what you just quoted, which I thought was really interesting because normally we see like 1%, 5%, and those are the patients that you don't really know what to do with. But traditionally we've done IST first and treated them like that's what, the severe aplastic anemia studies right now are looking at. Should we take all these patients to transplant earlier, et cetera? But those low levels, you at least kind of traditionally used IST.
I was just. Oh, awesome. I got it. Thanks.
Yeah, I have a different practice. I take them to transplant because I'm a transplanter. No, not really. Like, but because of all the reasons that IST doesn't work and the other clonal hematopoiesis you get. But if they are aplastic coming to transplant with a PNH clone, I do make an adjustment in my conditioning at that 30% amount. So I don't necessarily use eculizumab or complement inhibition in going into transplant during or anything like that, but I do bump up my radiation dose to make sure I'm ablating that clone.
Okay, that was a great debate. So Sarah and Beth, we in the back for autographs afterwards. We're going to take a quick 5-minute break for the last session. We have to reset the stage again. This will be the long-term follow-up panel session. I know we're running behind. I know a lot of people need to get out, so we will try to transition very quickly, but get a bathroom break, get coffee. We'll start in 5 minutes. Find their seats. All right. So I'm going to quickly introduce our panel. So again, this is really a topic that within NICER we've talked about for quite a while, and I think this certainly session is well anticipated amongst our group. So I'm going to do a quick introduction. When when I can. Again, I think a couple of our panelists have to leave. So again, it's not because they got upset like our debaters. It's just that they have to catch a flight. So JP Lopez, he's an immunologist who trained at the Icahn School of Medicine at Mount Sinai. He then moved to UH Rainbow Babies and Children's in Case Western Reserve in Cleveland. So he sees pediatric and adult immunology patients and does translational research with his main research interest being immunogenetics and immunodeficiency and immunodysregulation. Dr. Daniela Schwartz, she completed her MD degree at Wake Forest. She completed residency in internal medicine at VCU, where she also served as chief medical resident. She did her fellowship in rheumatology at the NIH and did a postdoctoral fellowship in T-cell epigenetics. In 2022, Dr. Schwartz was recruited to Pittsburgh, where she is an assistant professor in the Division of Rheumatology and Clinical Immunology. She runs a lab that investigates genetic and epigenetic mechanisms of immune dysregulation with a focus on Th9 cells and genetic immune dysregulatory diseases. She is the research director of the Pittsburgh Immunogenetics Discovery Center and co-director of the UPMC Autoinflammatory Center of Excellence. Dr. Kristen Evans is a pediatric BMT and cellular therapy physician at mHealth Fairview Masonic Children's Hospital and associate professor at the University of Minnesota. She leads transplantation, gene, and cell therapy efforts in inborn errors of immunity, telomere biology disorders, and epidermolysis bullosa. Dr. Evans greatly appreciates fruitful and rewarding collaborations in clinical research in multiple national and international consortia, as well as consult work and novel therapies for these fascinating disease. At Minnesota, she serves as the Minnesota Department of Health Newborn Screening Advisory Committee in the SCID Newborn Screen Triage Team. Dr. Ramajasti, who has actually trained many of us here, including myself, has an extreme interest in the neurologic and neurocognitive late effects in pediatric solid tumor survivors. She has another strong area of interest in cardio-oncology, with particular interest in prevention and early detection of therapy-related cardiotoxicity. She directs the general survivorship clinic as well as pediatric cardio-oncology survivorship clinic at Mott Children's Hospital in Ann Arbor, Michigan. She is also the site PI for the Cancer Control Survivor Study Consortium for the University of Michigan. So I'll welcome Rama to the podium first, and she's gonna, I think a lot of us who trained in HEMONC, we've really been able to see the growth of survivorship treatment, which I think can be a model and something that we can follow in our patient populations that are not in the oncology group. And so Rama, being an expert in this area, is going to give us an overview of how that has developed over time.
Brief review some of the impact of the survivorship knowledge on the frontline therapies, and leave with a one of my cases that is an exemplary case when it comes to survivorship care. So the good problem to have, we have more than 85% of the patients who are long-term survivors, but unfortunately, they tend to have a lot of morbidity and mortality as a consequence of the therapeutic exposures. So as long as we have some of these focused surveillance guidelines and guideline-related care in our late effects clinics, that has helped implementation of some health-preserving interventions. This is kind of a figure, shows that a good problem, but it's kind of an increasing problem in the sense, if you look at the number of survivors, By 2040, we expect the survivors to increase. And this graph kind of goes from 1960s to 2040s. And we expect that there is more than 500,000 survivors in pediatric oncology. So the need and these chronic issues truly exist. Though the survivorship journey is kind of acute to transitional to chronic, what we really are facing with now is more of the chronic issues. These patients have elevated risk of chronic illnesses and elevated issues related to late mortality. This is kind of a slide that I use a lot. And if you look at, oh gosh, did I do that? I'm trying to find, oh, there it is. If you look at the left column, these are the control population, and these are all the survivors from different diseases of pediatric malignancies. And this is looking at the grade 3 to 5 cumulative incidence of chronic health conditions. And as you can see, these chronic health conditions are significantly more of an issue in the survivors compared to the control population. And certain chronic conditions such as cardiovascular disease continue to increase as the patients go through 30s, 40s to 50s. This chronic burden on these survivors is a real issue in the sense that we tend to see more and more of frailty, accelerated aging, and then appearance of these chronic illnesses earlier and earlier in our survivors. And then this kind of results in what they call is an excess late mortality based on the CCSS literature. And excess mortality is defined as mortality beyond 5 years from the diagnosis. So this graph here shows for the patients who are more than 10 years from the diagnosis, the mortality is significantly higher. And what this essentially means is that this mortality, because it's beyond 5 years, is not related to their underlying disease. So this graph here shows that these are the disease-related mortalities, whereas the farther you go, you have mortalities related to other conditions, whether it is cardiovascular, pulmonary, or any of the second malignancies or late effects. As we talk about data in late effects community, we always want to know what can we do about it, and are there any modifiable risk factors? And so in this paper, they actually looked at these late mortalities and also looked at the different modifiable risk factors. And if you look at these three graphs, the top and the bottom one, the patients who were healthy, had this late mortality, but excess late mortality, but that was much better than patients who had unhealthy lifestyles. Also, if you look at other modifiable risk factors like cardiovascular risk factors, the patients that had no cardiovascular risk factors had less excess late mortality compared to the patients who had more than 2 cardiovascular risk factors. So it's not just learning about, what are the chronic health conditions, but what is it that, we can do, and how can we educate, and how can we prevent these? All of this data has come over the last, I would say, 40 to 50 years. So back in 1970s, when we started having survivors, we realized that patients do have treatment-related side effects. And a lot of that data came from single institutions. A lot of it was descriptive studies. And then the very first NIH grant was awarded in 1972. We had about 5 institutions that are part of this group. Eventually, it was 11 participating institutions, and they reviewed about 9,000 charts. Initial data showed that a lot of the side effects were attributable to single agents. So whether it is anthracycline-associated cardiotoxicity or hearing loss from platinum group or drugs, but the attributions were the initial data. Essentially, over time, we have learned that there are genetic predisposition to late effects. There is relevance to age at exposure and other host factors as well. The big change and I guess big advancement in the data collection came when we had cohort studies. So CCSS is the Childhood Cancer Survivorship Study, the very first CCSS grant. And CCSS is a collaborative multi-institutional study that is funded by the NCI. And this happened in 1994. Initially, there were some 20-some institutions. Now there are 31 institutions, and there are more than 25,000 survivors that are actually participants. There were more survivors, but this is the number that actually participate in different cohort studies. For these cohorts, we have retrospective data from the chart review. These patients were diagnosed between 1970 and 1999. There were 2 sets of cohorts, initial and an expansion cohort, but essentially that ends at the diagnosis of 1999. There are discussions, and we just had our initial collection of the patient numbers for the potential new cohort for the patients who are going to be diagnosed between 2000 and 2023. And obviously, these patients are going to have different therapeutic exposures a lot more targeted therapies, and then modified therapies based on the initial modifications based on the toxicity. But this cohort has not only helped with what we know from their chart review, but they have gone through 8 separate surveys over the last 40 years. And there's been more than 441 manuscripts published by CCSS related to all aspects of survivorship care. The other cohort that also has significant number of patients, meaningful data, a lot of blood and tissue samples and biologic information. And also these patients actually come to be seen at St. Jude is the St. Jude Life cohort. In addition to the patients, they also have a control group of adults who do not have childhood cancers, providing even meaningful data that can be attributed to therapy. But in 1980s is when the pediatric oncologists realized that based on the side effect profile, that these patients actually need multidisciplinary care, and started establishing these late effects clinics. Most institutions do graduate their patients. There are some institutions that do have clinics that continue to provide care for the adults. So as we are trying to establish clinics, we also needed some structured guidelines. Children's Oncology Group, when it was formed in 2000, in early 2003 is when they first published the late effects guidelines from the late effects committee. These guidelines are screening recommendations that represent a consensus statement from a panel of experts that practice in the late effects arena. In addition to the guidelines, which are evidence-based, they are reviewed every few years, more recently every 5 years. And the most recent guidelines actually were published in October of 2023. But they also have health links, which we find very useful in our late effects clinics because these are simplified versions for our patients. And not only that we can provide that while the patients are in the clinic, but we give them these access to the link as we graduate, and also to the primary care providers, who provide the care post-graduation from our late effects clinics. So all this data that we have to be able to translate this data for meaningful improvement for upfront therapies, and there is multiple examples of that. Some of them are, significant changes in the upfront therapy. So for example, based on the survivorship data, we have changed our upfront therapy significantly. Most notable maybe is elimination of radiation therapy or even doing response-based radiation for certain malignancies. There are some primary preventions like using dexamethasone for anthracycline cardiotoxicity. The blue boxes are more like the strong evidence. There are some evidence that is emerging and some we have knowledge gaps. For example, the not as strong, but definitely data-driven is risk-based breast cancer surveillance. And then there are some that are not as strong. That is, we are starting to use some medications that are, trying to modify the cardiomyopathy risk. And this is like using beta blockers for cardiomyopathy. So this is just an example as we are thinking about, how to collect data, how to come up with guidelines and have consensus to treat late effects in immunohematology group. The impact is not just, upfront, but also changing the, frontline therapies. I just wanted to talk a little about this case because I didn't really go through much about the late effects issues, overall in pediatric oncology. I focused a lot on the chronic issues and accelerated death and aging issues. But this kind of gives you a overview of the spectrum of issues that these patients face and the help that multidisciplinary care in the long-term follow-up provides. So this kid, when he was 4 years old, he had medulloblastoma. He had craniosspinal radiation chemotherapy. Initial late effects were hearing loss, panhypopituitarism, growth failure. A lot of mental health anxiety issues, neurocognitive issues were significant, and school difficulties. And with the help of the family and his late effects clinic, he was trying to battle through these, trying to set goals for himself. And as a teenager at age 16, he had the diagnosis of secondary osteosarcoma in the mandible from the posterior fossa radiation. We treated him as much as possible with osteosarcoma-directed therapy. He fortunately was able to have a resection. And that chemotherapy left him with a significant renal dysfunction, cardiomyopathy, frailty, poor appetite, poor weight gain issues, osteopenia, hypogonadism, sleep apnea. He has multiple NEVA in the radiation fields, scarring and facial asymmetry. But significant issue that is challenging for him is the neurocognitive issues. And he always wanted to make sure that he was competitive as his siblings and not be a burden to his parents. And worked with the neuropsychologist and had difficulty in college, but wanted to really be an insurance agent. And he had to take a test to be able to truly be an insurance agent. And he took this test 8 different times. Thank you so much. 8 different times before he was able to pass it. He's successfully working as an insurance agent, has transitioned his care to multiple adult providers, including cardio oncology. So this is kind of a, highlighting a patient that obviously with the help of the providers and the clinic and neuropsychologists and psycho-oncologists helped him be successful. But I think most important thing is also the family and the family support. So with that, I'm going to stop and ask our next speaker to come and talk about actually relevant stuff for immunohematology.
So for this next section of the long-term follow-up panel, we'll have very short presentations that are kind of case-based, and then we'll have a short discussion after each of those cases, and then wrap it up.
So now that you've heard what happens when these transitions work well, you're going to hear about what happens when these transitions utterly fail. Welcome to my world. All right, so I'm going to tell you about a young man whom I still follow, and this gentleman started to have problems when he was about 5 years old, when he started to have recurrent fevers, fatigue, lymphadenopathy, and malaise, and he had an extensive infectious workup. It was negative, it was steroid responsive, and he started to have recurrent fevers 5 or 6 times per year, which progressed until he was 14, when he had a very severe episode of pericarditis and erythema nodosum. And he was initially thought to have maybe some autoinflammatory disease, started on some steroids, they worked great, and now he's getting flares 3 to 6 times a year and getting lots of high-dose steroids 3 to 6 times a year. Develops uveitis, aseptic meningitis, recurrent pericarditis, is put on lots of disease-modifying drugs, including methotrexate, mycophenolate, really not much help, not too surprising. Eventually goes on TNF inhibitors and they do nothing. And then at age 19, he's seen at the National Institutes of Health, and they say what most of us say who treat periodic fever syndromes, which is, why haven't you tried some anakinra? And he goes on anakinra at 100 milligrams daily. And he has a partial response, and he goes back to the NIH and they say, how about you go up to 200 milligrams a day? This is a big guy. And he goes back to his now adult rheumatologist, who says, oh no, he's maxed out. 100 milligrams per day is the FDA approved dose for rheumatoid arthritis. We can't go up. That's dangerous. And so he stays on 100 milligrams per day of anakinra. And eventually he develops myasthenia gravis, which is diagnosed by a really good neuromuscular specialist, is put on mycophenolate, and that resolves his myasthenia, but he's still having periodic fevers that are treated mainly with steroids. And then this goes on for about, unfortunately, 10 years or so. And at the age of 32, he starts to have some abdominal pain, and he sees a colonoscopy. He sees a gastroenterologist who does a colonoscopy, finds some ulcers, and says, well, it's not Crohn's. So I'm not really sure. I think it's probably functional. And treat him with some antibiotics. This happens all the time. And about a month later, he starts to have very severe abdominal pain. And he goes to the hospital, and somebody sees a little bit of air under his diaphragm and says, take this man's colon out. And that is what happens. He undergoes surgery, and he has, it says sigmoidoscopy, that should say sigmoidectomy with a colorectal anastomosis, and he is discharged home. And after a week, he comes back and he has a big fluid collection in his pelvis. And they say, oh gosh, he's infected, stop his anakinra. And that is done and he gets worse. And he started on antibiotics and they don't do anything. And he's starting to have fevers and his blood cultures are negative. Adult rheumatology is consulted and he started on high dose prednisone and he doesn't get better. And at some point somebody says, he has an autoinflammatory disorder. Maybe somebody should call the autoinflammatory center and see what we should do. And that's when I got involved in this case. And I said, for the love of God, please put this man on anakinra. And they did. And this is not, I think, showing up so well, but fluid collection. No fluid collection. And so this story does have a happy ending in that this man is now on IL-1 blockade and they have rejoined up and reversed his colostomy and he's doing quite well on good doses of anakinra. But I think this case highlights some places where our system really fails patients as they transition from the pediatric setting to the adult setting. And so I brought up these questions as a real and this happens a lot. This happened, I mean, not with the abdominal surgery, well, yeah, with the abdominal surgery, but not quite this badly, but these sorts of failures happen a lot. So these are the questions that I am gonna take this microphone and bring back to my co-panelists and to discuss. What are some key differences between pediatric and adult approaches to rheumatology, immunology, multidisciplinary care? How should we be treating these patients differently from patients with common immune-mediated diseases, rheumatoid arthritis versus autoinflammatory disorder? Are these things lost in transition, and how can we make transitions better?
The first thing that comes to mind for me is the concept of like a unified treatment and multidisciplinary involvement in a medical home. And in pediatrics, we're paternalistic enough, I think, to have medical homes for most of our patients, or, you know, the primary team takes over but gets advice from everyone. I feel like a lot of the adult patients I hear about get piecemeal care, and every member of that piecemeal team thinks other members have already thought or tested for something or have already considered some approach, or they restrict themselves because they only know dosing for one thing and maybe this is kind of like that, so I'm going to do that.
I think coming from the allergy immunology side, it's interesting because we do have the benefit of seeing these patients all lifelong, right? So we're able to, especially in the space of immunology, catch some of these patients as newborns and then take them throughout life. So we see less that disconnection if they follow at an institution where you can see them going through there, but we do see that disconnection with all of the other specialties, as Kristen was saying and as you were mentioning as well. And I think part of the problem is that due to the needs, probably in the pediatric populations, all the specialists are identified for these patients. Once you realize they have a specific condition that needs X, Y, or Z in terms of specialty. The problem is in transition to adulthood, because I think that will be very center specific, but these are rare diseases, right? So probably can count how many centers have an autoinflammatory center for adult patients, right? Or even for pediatric patients, right? Yeah, so that makes it tough, because sometimes if you're a pediatric hematologist, oncologist, or a pediatric rheumatologist, you're doing your due diligence of identifying a provider that will follow up your patient, but it doesn't necessarily mean it's a provider with knowledge or specific knowledge for that, and they need a house from that standpoint, right? So at some point, even though this is not super exciting or sexy for institutions, is how much these multidisciplinary clinics need to be a continuum through life and not specific for those ages as well. Developing the level of comfort either for pediatric providers to follow these patients lifelong, or for adult providers to be a mandatory part of this group as well.
And I think that one thing that I've really noticed since, especially leaving the NIH and coming to a more sort of conventional medical center, is that adult medicine is very based around guidelines-driven care, studies in thousands of patients, and everybody wants a guideline for everything. And when you try to do something like care for rare disease and there isn't a guideline, you know, people say, wow, you're a cowboy, you're doing these really high doses of anakinra. And what guideline are you using to drive your care? That everybody wants the checklist to click through and the criteria to go through. And so this is a real issue, I think, and a difference, because in pediatrics, you have a lot of diseases that don't necessarily have guidelines, especially in the rare disease world. But even rare adult diseases like myositis and scleroderma in the rheumatology world do have some sort of guidelines that people go by.
Don't forget, it's not only that, it's also the insurance part in the real world versus the NIH approach.
Oh, I deal a lot with insurance. You can get past insurance though. I mean, you just have to yell at them a lot and argue.
One of the basic things that we see in our survivorship world is starting the transition early. So we talk about, even though if we do 18 or 21, we start the conversation 3 to 4 years ahead of time, saying, you know, this is the year, this is the year. We actually document it in the chart and share with the patient. So it's kind of, you know, obvious to them that it is going to happen. And then encourage them to, you know, make sure that they have the right people in place. So I think, you know, at least that is somewhat helpful. And the other thing, you know, being in a children's hospital and having adult colleagues, you know, identifying the right transition people. I mean, if you're trying to transition a pediatric cardio-oncology patient, if there's an adult cardio-oncology center, it's, you know, much easier to do that transition and making sure that they're actually following through.
Yeah. Yeah. So, oh, thanks. Yeah. So this next case that you have up here, I'll just comment at the University of Minnesota, where we're looking for a clinical immunologist, always apply early and often. Also, we're fun. You're going to come to our city next year. You're going to love it. We don't have immunology, like really at all, on the peds or adult side. So we kind of fill this in. And so those of us who have an interest in clinical immunology and immunoheme meet about monthly to go through complex cases and discuss them. And this was a case presented by our a lovely near retirement hematologist who is a non-malignant heme transplanter as well, who has a cohort of CVID patients he follows because no one else does. And he brought this case to our attention and was just a little bit flummoxed about what to do with this patient. And this is a patient he, I believe, started following as a teenager, but she's now 44. She developed what was called JRA back then at the age of 2, and then was diagnosed with CVID. So she's been on IVIG replacement, and then got some progressive chronic lung disease, bronchiectasis, kind of what we expect to see. She was on Plaquenil and lots of prednisone. When she was 20, she got ITP, so they took her spleen out. She has a diagnosis of nonspecific IBD, and like your patient has had surgeries in her abdomen to try to work on that. She developed a non-Hodgkin's lymphoma, so she got rituximab, not just a course, it was given continuously beyond that every 6 months. And then she developed psoriasis. She's tried some different, slightly more targeted therapy, as you see there. She's had various infections over the years, so TB, pulmonary aspergillosis, candidal peritonitis. That was a fun clean out that needed an ostomy that didn't heal well. Meningitis, itises of all the locations with all the doctors looking at different things, multiple lymph node resections to look for some reason. And then side effect from meds, osteoporosis, GERD, seizure disorder. The pulmonary function has declined over the years, and she became vent dependent, not 24 hours a day, but 10 hours overnight, oxygen all the time. And so this provider came to us and said, hey, we sent genetic testing. Like, what would make you think of sending genetic testing? Like, when would you guys start thinking like this might be some sort of genetic disorder of immune dysfunction that we should look for? And so I wanted to plot out her course and ask you guys, when you look for this, are you, are you looking for a mix of phenotypes? Or are you looking for like more than one autoimmune disorder? Are you looking for autoimmunity, an infection or a type of infection? Are you looking for a lymphoma to come up? I mean, these are all classic things that run together, and we see these, and you see this and I'm like, you're kidding me. This patient never got testing, but got testing, has 2 pathogenic variants in LRBA. And to make myself feel like I was crying reading her chart, it was so sad. I'm like, okay, well, it was only described as a disease really, in 2012. So she was 32 then. And abatacept wasn't really even around until 2015. So, but that's still like 10 years ago. She could have had an eruption in her disease course if we were thinking of these things. Many people here in the room are familiar with, and we've talked about a lot of the classifications that are kind of ridiculous, but the overlap in CTLA-4 haploinsufficiency and LRBA deficiency, and that they can both be treated with CTLA-4 pathway targeting. So clinical manifestations are this combination, right? Autoimmunity, multiple types, multiple organs could be involved, hypogam, lymphocytic interstitial lung disease. Certainly I didn't put up their risk for lymphoma, but risk for lymphoma, and that there's good treatment. And there may be other treatments that could be used as well. So the questions I was thinking with this case is that question of what constellation of diagnoses, symptoms, manifestations make you think of genetic testing. And then once you test, perhaps she had been tested 20 years ago. What's that going to tell us? Like, how often do you need to revisit that? Then I was thinking about the medical home question and subspecialists and collaborating. We shared a patient we were talking about at Michigan that I assumed had been fully genetically investigated for very early onset IBD when we got this patient as a lymphoma patient, and it had never been done. So just asking those questions. And then finally, what obligation do you have when you have a former patient and suddenly one of their variants that you had tested for that was, a VUS initially is now reclassified? Like, do you need to find that patient, reach out to that patient?
I think just gonna go quickly before Zhao. I wait for the third fungal invasive infection until deciding on doing genetic.
After the surgical.
Yeah, after the ostomy is on, I think it's the time to do it. This naturally changed quite a lot, right? So it's also the sign of the times, as you were saying. Some of the diseases, I have a very similar case to yours with a kid with APDS that ended up being transplanted for CVID, and there was no gene and all of that stuff. And this just changes a lot with what times change. So it's easier now for us to approach some of those, even though at least the CVID diagnosis was there in the teen years, right? And I know it was 24 years ago, but can we stop taking spleens out of people for the sake of it? Just putting a word out there. But I think a lot of times the problem is when these patients get to us, they already are genetic testing material, so the question doesn't come up as much, right? In a way, it's more like, how can we make sure that this constellation of phenotype and diagnostic workup gets to us as quickly as possible so that we can proceed to do that, and not a question of if, is a question of yes, and how quickly we can do it as well. It's tricky, the last question you have over there, just comment on that one quickly, about the obligation. Some companies do report when there's a reclassification of variants. Classification of variants is also so iffy as well, because so many times you'll know that whatever they have as classification is not valid and vice versa. But I think theoretically I would still try to search my patient and my family to let them know about a result if it had impacts in their phenotype. Yeah.
So I think one thing that is important to remember about the adult world versus the peds world is that there's really a misconception in adult medicine that if there was a genetic disease, it would have been discovered by now. And people don't realize that, in 1990, there was not genetic testing because these diseases had not been discovered yet. It's a very simplistic, well, we knew about sickle cell disease, so of course genetic testing would have been done by now. And so I think there's a real lack of awareness and a need to educate adult providers. So any of you who have med peds centers, give grand rounds to your adult providers, make them aware, and then there should be a pathway. A lot of times the genetics department is in the Department of Pediatrics, and so getting an adult patient over to genetics for genetic testing can be very challenging, even if you have those resources. And then insurance coverage can be challenging because it's an adult. And why would you do genetic testing in an adult? So there are a lot of barriers to care at the social level, at the logistical level, and really at the educational level. I'm a fan of testing early and often, as I think most of us are, because I don't think we'll understand the spectrum of these diseases until we start looking and there are various penetrants. But it's just beyond that, because people have to know that genetic diseases are things that affect grown-ups.
So, I had the same issues that you guys did when I started at Hopkins. And certainly there were a lot of amputations and spleen removals and, you know, this person's been on steroids for 35 years. What do you think is wrong? I mean, they're doing fine. So I will say, even more than all of these things, I find that medicine right now, especially adult medicine, is struggling conceptually with this emerging world where there are clinical diagnoses and molecular diagnoses. And the fact that they're conceptually not on the same level, but seem to be conflated in a lot of people's minds, is something that needs to be communicated broadly and widely about. That's the first thing. The second thing is that genetic testing itself is not genetics. Okay, so genetic testing is a tool, like every other tool. And one of the most important things, I think, in terms of the education that Danny is talking about, is to make sure that all of our providers understand that there is a very vast range of tools at their disposal for immune-mediated disease that we have the luxury of having access to that a lot of other fields may not. But going back to the med peds thing, so one of the reasons I actually liked working at Hopkins is because of the fact that the genetic medicine department was freestanding and not embedded within adult or pediatric medicine. But actually a lot of pediatric genetics divisions also do see adults, and you know, like my practice right now is probably 60-40 adult to kids, even though I'm pediatrics trained. And I think the reason, of course, that a lot of geneticists started out in peds training is because kids are not little adults, right? But there is, I think, also a need to educate your geneticists, because geneticists are so used to dealing with a lot of earlier onset conditions that they may not understand the paradigms behind certain, you know, more post-reproductive phenotypes. I mean, I frequently get asked, why are you doing genetic testing on someone who's like 75 years old? Like, you know, move on. That 75-year-old had 2 Mendelian immune diseases. But the thing is, I think there should be like you said, a very, very low threshold for being involved for any kind of immunogenetics evaluation. And it should not just be based on diagnostic genetic testing. A lot of times, I will say yes to pretty much anyone who asks me to see a patient in order to be able to do education, in order to be able to sort of use that as a teaching opportunity, regardless of whether or not I have strong suspicion for monogenic, polygenic, digenic, or, you know, oligogenic disease. That's not the point, right? The point is to be able to try to communicate about how we use assays, how we think about the clinical diagnostic framework of immune-driven disease, and also to try to promote communication, because there are a lot of silos in adult medicine where people just communicate via notes but don't actually talk to each other. And it's actually been amazing to see during my time at Hopkins, when people are desperate and they actually get you involved finally, and there is one success story, promulgating that success story and getting more people involved has actually been very effective in getting more and more adult providers to get on board. And even to the point where now, for example, our adult IBD people get the pediatric IBD people involved if they have a weird treatment refractory case of atypical colitis. So, you know, trying to promote communication across disciplines, trying to always just be that obnoxious person in the PICU or the MICU, sort of sticking your foot into things, has been sort of really, really important. And then also simultaneously, you know, teaching really important conceptual things about immunity,
not just the immune system. I think that's another misconception, is that the immune system and immune disease means it's just another organ system and not something that you can find in every specialty. All of our patients have like 5 million different providers because their disease manifestations span so many organ systems, right? And also just being sort of present to teach about very important basic conceptual ideas over and over again.
All right, in the interest of time, we're gonna move on. Someone's supposed to have already left to get to the airport.
I'm not angry at them.
Me again? All right. Yeah, I've got one. All right. I think I need this. Okay. So next case is on parenting. So I'm going to tell you about this young woman that I follow with Blau syndrome. She had severe asthma in early childhood. She had episodes of red eyes, and she was always walking funny. And noted joint pain and stiffness in late childhood and adolescence. This woman, unfortunately, also came from a sort of disadvantaged background. She had a lot of trust issues with medical providers. And so she really never pushed, and she was never pushed. She didn't follow up regularly with care, but also she was told multiple times that this was sort of stuff that happened in childhood, and a little bit of joint pain and stiffness was kind of normal as you grew older. And so this was really never pursued. As she got older, she just kept on going with life, thinking that joint pain was a normal part of life. And then as she got older, she started to have kids who were really, really sick. And so her son was diagnosed with Blau when he was 4, daughter diagnosed with Blau syndrome at age 8. And they were both very ill, multiple hospitalizations at Children's. And then as they were taking the family history, mom had RA and had died at age 30 due to complications of childbirth, maybe retained placenta, which sort of had led to some of these trust issues. So the patient was tested for the NOD2 mutation at age 30. She was found to have Blau syndrome. And so in her initial rheumatology visit, she had really significant synovitis and tenderness. She had deformities in all her fingers. Very restricted range of motion in her shoulders. She had never had x-rays. She was not on contraception. She was not on therapy. And so we had a long discussion and decided to we said, let's do a GYN visit for contraception, x-rays, and immunizations. Because of insurance, we had to try at least a little bit of methotrexate before we could do a TNF inhibitor. So you always do 8 weeks and then you say they failed. Let's go on a TNF inhibitor. So obligatory methotrexate prescription can be written, but not on contraception. So you can't give someone methotrexate till they go on contraception. So subsequent rheumatology visit, the patient said, well, I wanted to go see my GYN, but my kids were in the hospital twice and I couldn't take time off work because I need to support my family. So I never visited my GYN. So I didn't start my methotrexate. So I feel exactly the same. At which point I said, okay, well, let's just start you on contraception here. And we can do SLIND, which is relatively safe. Insurance denied SLIND, but then we got it approved and started methotrexate and said, let's come back in 3 months. And the patient's children were hospitalized multiple times again, and she has not been back. And we're still trying to reestablish care because her children are sick and she's not able to take time off of work to come back in to check her maintenance labs to make sure that the methotrexate is not poisoning her liver or her marrow or anything like that, and has not been in for a visit since then. So this is an issue that comes up a lot. Parents who have sick kids and have genetic disease, they're all sick. And physically, there are 2 hospitals with 2 different kinds of centers. And parents who are particularly resource limited don't always have the ability to come in and take care of themselves. They always prioritize their children because they're good parents. And then there are also sometimes trust issues. Like in this case, this patient's mother died after having retained placenta, and she has really significant trust issues with sort of the medical profession in general. So I will turn this over to panelists.
So I can probably speak to the last point, which I think is a very complicated question. And I think is something that you deal with a lot, not only in immunoheme patients, but even in a standard oncology patient that has a misdiagnosis. And I think, it's important to as providers really acknowledge that there is that mistrust and not, forget that with each visit that you're having. And really, I think continuing to establish that groundwork for a new relationship with families at each visit and having continued visits with them and really trying to mend that relationship over time and understand that it's not going to be mended in 1 or 2 visits. This is going to be a longitudinal process. And I think that really helps me when I'm taking care of these patients.
Recently in our clinic in the last 2 years or so, we have incorporated a psycho-oncologist and with the service that we did not have before. So we used to rely heavily on social work to uncover some of the, issues, whether it's a trust issue or, family issues that we haven't been able to uncover with our dialogue. And it's been really fortunate to have the psycho-oncologist because she comes up to us with information that, people have not discovered for a very long time. So I feel like it's a very, very valuable resource that, and she also not only just works with the kids, but also works with the parents. So in this scenario, your patient that is going through all of this, I think would really benefit from services like that.
I don't have a solution for this, but I want to echo this sentiment because there are so many times. So I can tell you, I have off the top of my head, at least 2 parents that when gain of function diagnosed only because we diagnosed the child. It was very obvious that both mothers had them. One ultimately lost custody of her child. Actually, but they both ended up losing custody of their children over time because they had other psychiatric issues, probably from being told their whole life they were non-compliant with their medications. BCL11B, we have CTLA4 Heplo, we have where all of these cases, we have diagnosed the parent because only because the child was seen in our clinic. And the problem is that I'm happy to see them both because with allergy immunology, I have the luxury of seeing adults and peds. It's not a problem. But then I don't have pediatric hematologists who are willing to see this 45-year-old in my hospital. I don't have a pediatric pulmonologist that's going to see this patient. So the care still remains fragmented because I still need them to go to the adult side and get infusions and see these doctors who are like, oh, I don't know what this is and are not communicating as effectively. So this is really the importance of these centers like Danny's autoinflammatory center that she came to Pittsburgh, got set up so quickly where she was like, I need peds people, I need adult people, we're going to get this together, where this care can happen because so many of these parents, I feel so terrible for them because I have their kids on the right meds and their kids are going, or their kids are headed to a transplant or they're doing well. And the parents are falling apart without good care in the community. It's really sad.
And thank you for the talk. I think yesterday there was an abstract that a grandparent who was 76 years old diagnosed because of the grandchild had the diagnosis, and with the right treatment, his cardiologic wise, he was doing better. So that's very impressive. And I really feel in different parts of this. And I think one approach is, I don't know if you encounter, but some physicians kind of, dismiss those patients from their clinic because they do not show up. And I don't know the exact legislation, but like I think there is a right for the physician to dismiss from the whole department if they don't have show-ups, which comes with like overall bias to directed to those families, and probably they're stigmatized, and like wherever they go, it goes with them. That's one part. And I was wondering, still being welcoming, if that's the case, not other issues for sure. And telehealth option also, sometimes if they have limited time to take off the work, and multidisciplinary clinics, as what other colleagues were saying, that includes, for example, for vascular anomalies that we have in our center that includes both the adults and pediatrics, but they were seen in the same clinic on the same day, might be one approach. Thank you.
All right, we're going to move on to our next session, and I apologize. I think I need to introduce you, so I'll introduce you now. So also have the pleasure to introduce Rohini. Oh, you have another part.
You would want me to do one more case, but we can skip through it. It's some of the
Is that
same.
okay? Maybe
Yeah, yeah, we
fertility section.
Yeah, because we're running late.
Yeah. So this is Rohini Chakrabarthy. So she is, can I say day 6? So the University of Chicago was very lucky to recruit her to be an assistant professor in pediatric bone marrow transplant and cellular therapy. So welcome to Chicago at the University of Chicago and Comer Children's Hospital. She has clinical interest in transplant and cellular therapy for pediatric malignant disorders, but Rohini has really developed some expertise in long-term effects with particular interest on fertility and reproductive health in her patients. And I will mention there has been actually a big discussion among multiple people here of looking at this topic in our area. So I'm hoping you can help us not only today, but moving forward, maybe not day 7 of your attending life, but in the future. So
In a week, yeah, give me a week. Thank you guys for having me. I am probably going to leave you with more questions at the end of this than answers, but I think there's a lot of room for us to be able to collaborate and kind of develop studies going forth in this topic. So these are just a few cases or scenarios just to frame the next couple of slides. So as a malignant transplanter, for example, you have a 15-year-old male who has been newly diagnosed with high-risk ALL. He's about to start therapy in the coming days. And he is planning to bring in just a high-risk leukemia therapy with conventional chemotherapy, but definitely we don't know if this patient down the road is going to be needing some sort of cellular therapy and or transplant. And then you also have a 7-year-old female who has a history of cytopenias over the last several months and has been newly diagnosed with idiopathic severe aplastic anemia. Thus far, she has had a fairly extensive genetic workup with no known genetic predisposition or genetic driver mutations. She does have a matched sibling, and you are planning to proceed with a matched sibling bone marrow transplant in the coming weeks. So you are part of the multidisciplinary fertility team in your institution. And how do we really think about counseling these patients? What are we going to be talking to them about? What are we going to be telling them about their risks, and how do we think about them? I think you can have an entire session on fertility in this population. You can have another entire session on reproductive health, which is a totally different topic. That being said, hopefully over the next couple of slides, I can just highlight the importance of discussing this topic with patients across the board, as well as highlight some of the very broad guidelines that do exist right now, and then really emphasize where the gaps are and what we really need to be thinking about as providers and researchers going forth. So most of the data that does exist and has been extrapolated from the childhood cancer survivors. That's where we have the most population to really think about. And so that's where a lot of this information comes from. We know that survivors of childhood cancer consistently on various surveys are reporting that fertility and reproductive health are important things that they want to learn about. And it's something that they feel that we as providers are not talking to them about. They often don't even remember these conversations. And part of that comes from the trauma of the initial time when you're diagnosed. However, we really as providers need to be continuing to emphasize this topic over time so that they know what risks are for them. We know that childhood cancer survivors desire future children and are interested in talking about fertility options. Whether those are viable options for them in the moment or not, they still want to hear, what are the options? Am I able to pursue these options in a timely, safe manner? Or is this just not an appropriate thing for me right now? And then cancer survivors do place a higher value on parenthood. That has been reported in a variety of different studies than those who don't have a history of cancer. So again, these are just points that emphasize that our patients, whether they are young adolescents or older patients, want to talk about this. Parents want to know about this. And really anecdotally, I think all of us as providers, those who are oncologists, transplanters, we can sit there and talk to a family about their risk of dying from infection, their dying from cardiac complications, et cetera. But the moment you bring up the risk to their ability to have children in the future, I think that's where we really see that emotional response. And that really highlights that we are not only thinking about what is happening to them in the immediate moment, but that this is going to be a lifelong issue for patients, even if they are cured of their disease going forth. There are a variety of different things that we do to talk to our patients about their fertility risks. And this is really a multidisciplinary conversation, and it's going to involve a lot of different components, whether that includes their underlying disease process and what that disease actually does in terms of fertility risk, therapies that they've had in the past, therapies that they may be incurring in the future. But objectively, back in 2015, the cyclophosphamide equivalence dose calculator was developed. And that is a calculator. I've put a link to the Pittsburgh CED calculator, but there's also one out of St. Jude that really converts all alkylating agents into a cyclophosphamide equivalence dose. And then those are tallied up and you get an overall total score. And that will correspond with some of the risk stratification that we do for patients in terms of their risk of infertility later on and how we are counseling them on their fertility preservation options. While this is a great resource, it's something that is objective. We all love objective things, numbers, data. This is just one component, right? This is one number that you're thinking about, but you are not taking into consideration the age of the patient, the pubertal status of the patient. You're not taking into consideration what their underlying disease does to their fertility risk. And so it's definitely not a perfect system and is definitely incomplete. And then back in 2020, the Pediatric Initiative Network out of the Oncofertility Consortium developed a little bit more of a comprehensive risk stratification guide to patients. This, just of note, comes from patients who are childhood cancer survivors again. So this does not take into consideration our immunohematology patients and doesn't necessarily take into consideration patients who went to transplant as well. This is primarily those patients who received conventional cancer therapy. So they created two different tables, one for males, one for females. And the various rows correspond with the various types of treatments patients got. So it does take into consideration that cyclophosphamide equivalence dosing, whether they received a transplant, other heavy metals and radiation exposure. And then they have classified these patients into 3 different risk categories. So minimally increased risk, significantly increased risk, and a high level of increased risk. Again, more comprehensive than just doing one objective number. That being said, I think it doesn't take us long to be able to know that there are a variety of different holes in this as well. As a transplanter specifically, you can see that all transplant is just lumped together and you are classified as a high risk of having fertility complications later on, when in reality, that probably is not the case. There's going to be a variety of patients, particularly my malignant patients who come to transplant who have had an abundance of therapy prior, who may definitely be in that very high risk category. But if you have an idiopathic aplastic anemia patient who is getting fairly minimal cyclophosphamide dosing and otherwise has not had any therapy, they may not actually have this very high risk. But the thing is, we don't actually know. So right now, this is what we have in terms of objective information. So specifically, how do you approach patients in terms of your immunohematology patients? And again, unfortunately, I don't have a perfect answer for you. I'd love to hear what other people are doing at different institutions, but I think it's important to emphasize this is very complex. There are no set standard guidelines, but really, I think you need to think about a variety of different considerations, including their underlying disease process, any planned or previous therapies, and really utilize your institution's fertility preservation team that's available to you. A lot of institutions over the last 10 years have been starting to develop these teams, and they are multidisciplinary teams that consists of OBGYNs, urologists, as well as oncology transplant providers. And then you have genetic counselors that are there to assist you in terms of counseling patients who have inherited bone marrow failure disorders, et cetera, that may pass this along to any future offspring that they do have. And a lot of times these conversations are now being had in conjunction. So everybody is sitting in a room together with the patient. And I think that allows patients and families to really be able to ask various questions, and you have all of the experts in front of them to be able to have that conversation. Notoriously, as pediatricians, being a pediatrician myself, we're bad at talking about fertility and sexual function and all of that. But again, your 12-year-old patient is going to be thinking about this. So it is important as us providers to bring that up, because if we don't bring that up, they're not going to think about it until later on. And then what are you going to tell them 10 years from now when they're in your survivorship clinic and they were like, oh, we didn't hear about the fact that I might not be able to have children on my own. So just some concluding thoughts. Again, we have made some really great strides, I would say, within the last 5 or 10 years in terms of, you know, considering oncofertility as its own discipline, really developing multidisciplinary clinics, starting to put guidelines out there, and really have a multidisciplinary approach to this conversation. But again, we definitely have gaps in terms of what are we facing in terms of actual risks down the road. What are newer therapies going to do for patients? Cellular therapy, immunotherapy, all the wonderful targeted therapies that we talked about, and really focus more on immunohematology patients, or as we are treating them more and identifying them more. NAPAC actually has a survey in progress right now that has reached out to various different programs in order to understand what different institutions are doing in terms of this exact counseling for their patients. And we hope to be able to gather some of that data and develop future guidelines for providers in this particular area. And really, this highlights the need for continued research and advocacy efforts. These are just 2 slides about, there should be 2 slides, but there's 1 slide about fertility preservation options for those who want to learn more. And then finally, some key questions that come up for me, and I would love to hear what people are thinking about, is at what age should we be having these conversations? Should we talk about this with everybody or just with certain patients? Who should be having these conversations? I think this should be a multidisciplinary approach, but people have other thoughts to this. What financial resources are available for those who don't have insurance coverage? There are almost 17 or 18 states now that provide some amount of coverage for fertility preservation for patients, but this is definitely prioritized more in the cancer population. That cancer diagnosis definitely kind of is highlighted a little bit more. So how do we advocate more for this in our non-malignant immunohematology patients? What are the ethical considerations when we're having these conversations? And then how are people talking about immunotherapy, cellular therapy, et cetera, when it comes to affecting fertility risk? So.
My way over, I'll just say I have so many questions about our patient populations and all the different drugs they're on chronically and how that affects their fertility, but also then the next question, like, can they carry a child safely? Are things anatomically going to work? Those sorts, yeah, all those questions.
Yeah, so Kelly has been interested in this question for a long time, and we actually started a task force to deal with questions related to reproduction and fertility in patients with genetically driven immunoheme disorders. So would be happy to connect with you because we're also working on our own survey right now. But I think, you know, this is an amazing list of questions. I think the problem for a lot of people who are dealing with genetically driven immunoheme disease is that it's not, things are so different across all of the different kinds of immune landscapes. And sometimes, you know, the question is not about preserving fertility using all of those different strategies you've discussed, but simply making sure that the adult rheumatologist taking care of your FMF patient knows that if you treat the FMF properly, that patient actually their fertility might do better, right? So a lot of it, I think, for us really extends across the whole pre and post reproductive question spectrum with many, many dimensions of knowledge that we have no data on at present. And so hopefully we can all sort of work together to make that happen.
just piggybacking off of that, I think another really important thing to think about as we're doing this is in, again, the patients who have chronic conditions who are on medications. There is this new push towards reproductive rheumatology. And I think this is one place in which like women's health in the adult world is making big strides in the right directions. And we have now data on which immunomodulators, in patients, comparative safety, efficacy, and safety and efficacy, which trimester these various agents might be safe in or not safe in, placental transfer. So those data are there. But usually there's going to be, if anything, maybe one or two dedicated people at each institution, even within rheumatology. So like at our institution, we have one reproductive room person who really takes on ownership for a lot of these cases. And so identifying that person as it's really a growing field can be very helpful in the setting of, trying to change or preserve some of these immunomodulators during somebody's pregnancy or period of fertility.
Comments, questions, concerns? No?
Oh,
Yeah, so I know we're at 1 o'clock, but this last session, we have one more case, which really ties the whole morning together, I think. So it'd be great if Dr. Schwartz, if you're able to go a little extra, that'd be great.
I'll go a little, I'll go fast. So I guess I have a lot of cases because I see a lot of grownups. So this is this is a 66-year-old woman that I actually started following during my fellowship. And so she's been my patient for many, many years. And she came to me as one of my initial Hot 20 cohort that was used to sort of discover the disease. She was the mother of my index patient. And she, like many of my patients, had an early childhood onset of disease that was sort of orogenital ulcers, and then developed a seronegative inflammatory arthritis during her adolescence that was kind of written off and never treated. And then eventually was diagnosed with rheumatoid arthritis and started on a low dose of prednisone, which is what she came to me on, and was noted to have some recurrent fevers and Raynaud's. And she had a diagnostic mutation in TNF-AIP3, was diagnosed with HOT20. Her nieces and sister had more severe disease and had been diagnosed first, and then her mother had died of, quote unquote, sarcoidosis, but not. So initially she was started on anakinra. This was in the early days when we were sort of said, oh, A20 inflammasome, she'd failed TNF inhibitors, let's do this. And she did. She actually had a really good response, but she hated taking a daily shot. And so after a while, we started to see interferon signatures in these patients and say maybe some of them should go on JAK inhibitors. She had rheumatoid arthritis. And so getting tofacitinib had just been approved for rheumatoid arthritis. And so she went on tofacitinib, and she did really well on that, and stayed on tofacitinib for about 7 years, stayed in remission. And then just this year, she was noted to have a very small mass on a routine screening mammogram, and just had a couple of months ago, and was noted to have a stage 0 grade 3 triple negative breast cancer, and was just switched back to anakinra just because of the sort of safety profile and concerns of using JAK inhibitor in somebody with an active malignancy. Generally in rheumatology, that it's not done. And so clinically, she's doing quite well. She's getting her mass resected, and she's got plans to follow up with oncology for that. But she asked me the question, did the JAK inhibitor cause me to have breast cancer at the age of 66? And, I don't know. It's a small breast cancer. She was 66. Could it have been contributory? Could this have been a effect? But I think this brings up the issue of many of our patients are started on these JAK inhibitors now in childhood. And then as they get older, they're going to have, potentially cardiovascular disease or other complications where maybe somebody's going to want to stop their JAK inhibitor. And if they've got a primary disorder where JAK inhibitors are really, curative, let's say that they have one of the STAT mutations or an interferonopathy, what do you do with these patients, particularly if they have vasculopathies? And then not only in terms of JAK inhibitors, but many of our patients, again, if you're going to be on these immune modulators for 40, 50, 60 years, what kind of additional monitoring do we have to do? Running out. How do we adjust therapy as our patients grow older? And those are some of the things I think we need to think about as we start to see these patients age into adult clinics.
Great. I would like to know those things too.
So I feel like, I mean, I give you so many props for taking care of DUB patients because they stress me out the most. I feel like a lot of the ubiquitin pathway patients where there's multi-pathway inflammation, you have to worry about inflammasome activation, you have to worry about JAK-STAT activation, you have to worry about NF-κB. And, you know, most of the time insurance doesn't want to let you use more than one drug. So when you follow them through life, you know, how do you decide when to check their immune profile and grade their depth? Is it when you're thinking about switching them to a medication? Is it when they have a new novel symptom arise or progress in some way? Like, how do you sort of think about balancing all of those different pathways you have to worry about?
So I check it because I don't know what the state of immune activation is in these patients. I check it at least annually if they're in remission, and I check broadly. I check everything. I check, TBNK, I check immunoglobulins, I check interferon signature. There's no direct readout of inflammasome, but I at least screen them with at least CRP and S100, A8, 9, A12. I send the CXCLs and the IL-18 and all of that stuff. I do. I check everything at least once a year, and if they're having a flare, I check it again. Sometimes in these patients, and this is really challenging, they're having inflammatory symptoms and every serum biomarker looks stone cold normal. I have a 15-year-old kiddo who has what looks like strokes, and I put him on anakinra and they go away. And the only thing that I've found abnormal on him is a slightly elevated S100, A8, A9, and he has an interferon signature. And so, do I add a JAK inhibitor to his anakinra? That's sort of where we are right now, but he seems clinically in remission. And so I think these are really important questions. One thing we really struggle with is, do we go to serological remission or do we go to clinical remission, particularly in somebody who is 15 and has pediatric strokes? What are we going for? And it's scary. I don't have a good answer. I do the best I can. I check everything.
Okay, well, thank you again, panel. That was fantastic. Okay, I think lots more discussions need to be had in this area, I think. And so I think we'll continue to have those and maybe even consider this as one of our future topics in one of our research conferences in the near future. Do we have the next set of slides just for the closing? And we have some other gifts or awards, I think.
All right. Wanted to give the have the privilege to give this first award, the Rising Star Award. So this is to recognize an emerging leader with an exceptional contribution to the NICER mission and potential to make impactful advancements for immunohematology patients through clinical care education and our research. And this person has been quite instrumental for me throughout the course of this last year, coming on to the education group and really supporting that. So Chris, you are our award. And me being the photographer is not out there, so somebody's gonna have to. Yeah, make sure you get the picture of your.
All right, our next award is the Resonate Award, which is there to recognize the passionate drive to amplify the ideals of NICER and expand collaborative engagement within the broad immunohematologic community. This individual had the highest recruitment of new members to NICER over the next year. And this award goes to Zhao Peng.
Yeah.
Great. Well, thanks, Zhao. I think you single-handedly are working to double our group enrollment, so keep it up. She is very convincing. I know many of you in the room know this. I have the pleasure of providing our final award for today, which is the NICER Service Award. This individual is being recognized for the tremendous contribution to supporting the NICER mission by spearheading the research infrastructure with diligence and creativity. So Jim Connolly, please join us. I think he sent more emails than maybe even I did this year to organize research.
Pretty much. They spelled my name right this time. I think so. The email service award and space award. One of many stories from last night. So, all right.
I missed out. Have
All
an early
right.
bedtime.
And then do we have?
That's
Oh, God.
All right, and no plaques or other things with their names to hang up on walls, but we would like to recognize Sarah for being our host here. And so we have this beautiful bouquet of flowers.
Yeah.
So that's the next part.
Like your stuff. Dear Colin in the back, could you help us out? Yay. These are Jim's slides, so.
So for just 4 slides left, and then we can go along. So I was asked to give a very quick update, and this is hopefully a primer, a little bit of our next kind of get together, which can I mention the potential date? Is that safe to do? We're thinking April 11th for our next in-person research retreat, which has now become an annual thing, annual retreat that we do in Ann Arbor. We had talked about maybe doing another virtual session in the winter, so stay tuned for that as well. And so this is a Friday through Saturday for those of you who have not been to one of this. It's a lot of fun. We get a lot of work done though. So this is a working meeting, but there's lots of foods and wines for sure. So. Oh, okay. 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 Well, we'll have to find another weekend then. All right. Hash bash it is. Which is the other weekend we were considering. So it'll fit in well there. So anyway, all right. So this is the most greatest update that we have. So it was just this week, I believe. And so this has been what, a year process, somewhere in that range. So obviously a big piece of us doing this collaborative research is developing the regulatory infrastructure to have all of our sites kind of be approved to do this research and have all the contracting in place and all the reliance agreements. And so the first step of that is we've developed this parent protocol, which will cover our registry and our biorepository, and it's now approved. Thanks. This is Jenny's face every time she got a reply from the IRB. Of like, yes, that's very reasonable. I will change it for you. But special thanks to Jenny. She was fantastic. I know this is really hard work and frustrating at times, but you know, she was really the person who pioneered and got this through. All right, so Jenny, your next step is here is that, of course, now that we have this in place, is a whole lot of other steps. I think our plan is to have an executive meeting, I think shortly after this, where we're going to have a little bit more discussion about how we are going to take the next steps to build all the reliance agreements to make University of Michigan the central IRB, and how we are going to navigate research through all the institutions. But this was a huge step forward of getting all of this done. I think everybody's aware that we've been spending quite a bit of time at the both in-person and virtual retreats to build these data registries. Just to tell you the value of these in-person retreats we had, we were all proud of ourselves before of, you know, that, okay, we're about ready to actually start programming things into REDCap. And then at our last April retreat this year, we basically scrapped everything and then rebuilt this model. And Nick Ryder had a lot of influence on this. And again, this is the work of probably a dozen people that have been putting this together. And so from everywhere from the CRF development to kind of developing this infrastructure. And now we are kind of working with a lot of bioinformatic people to do this. The goal here is that we will develop an automated data extraction tool. And so relying upon some publicly available common data models through OMOP, which surprisingly, the majority of our centers have experience with. And so we will be extracting data locally into an OMOP common data model. There'll be an interface where data can transfer between REDCap and OMOP, which will allow probably most of the users, because of the wonderful userability within REDCap, to extract that data. But the OMOP common data model, which will be a much more extensive warehouse, so to speak, of data, could also be accessed. And the nice thing about this is that since OMOP is becoming a more commonly used platform across different infrastructures, is that if they are also using OMOP common data models, we'll be able to do that. So many pieces of this are kind of working in parallel in development, so we're excited about that. And the molecular registry, which again, a lot of people are working on this as well. But Mark Duchkowski, Zhao, and Charlie Billington have really been working on this aspect of this. And so really what we're hoping to do is really over time develop multiple omic registries. But the first one is a genomic registry where hopefully as patients are either getting clinical or research testing, that we'll be able to preserve that data and provide that resource for individuals who are very interested in obviously genetics and the impact that has on patients and their disease process. And then finally, this is really an amazing program, which Zhao and Sarah here are leading. We had our first Unhide session a couple weeks ago, which was awesome. It was so, I think it's educational. Obviously, we're there to help patients. It raises a lot of good questions about what we do and don't know. But essentially, I can't remember what Unhide stands for. Oh gosh. All right, so okay. All right, so my picture's not up here for a reason. And so, but so essentially what this is that we all have these cases, we all need help with them. None of us can work in isolation to diagnose these patients. And so this button kind of gotten tealed out, but essentially through the website, you can submit a case. And I won't go through all the flow that's there, but it gets reviewed fairly quickly. And the nice thing about it is that, you know, this is once the case has been reviewed, is that Zhao and Sarah, others are kind of developing this ever-growing network of experts in the field. And so the cases that we had a couple weeks ago, you know, they weren't specifically NYSER members. We had a lot of NYSER members there, but they brought in the experts. And so it was fantastic to learn from them and how they think through the case. Kind of think a stump of the professor, but like doing that in real time and for real cases that we need decisions on. It could be treatment decisions, it could be diagnosis decisions. It could be a lot of things. Does this patient need a transplant and so forth? And so we're looking for cases, and I think we'll have a little bit better idea of just how often we're going to have these meetings. And obviously, as we go through that, we'll certainly refine the process. But this is going to be a wonderful program. I think Zhao's and Sarah's plan for this is not just, you know, to kind of have a discussion, but like, okay, we have this variant, and can we connect you with a basic scientist who might be trying to validate that assay or can do that assay for you, and kind of having all those tools in place. Because I think all of us are frustrated by the limitations of the clinical tools we have for a lot of our patients that need them. So it's really going to be, you know, it's already a beautiful program, but it's really going to be continue to build upon what they've already done. So I think those are kind of really three big spotlights on what we're doing on the research side, amongst many other ones that are there, but I was only given 4 slides.
Well, the symposium wouldn't happen, I'm sure you guys know this by now, without Evelyn. Hopefully she's still in the room. So big round of applause for Evelyn. And then I did want to recognize Chelsea, who came here to help. She's been very invested locally in our immunoheme clinic and has very much enjoyed being part of this community. Perhaps she's already on her way home. I hope she is. But if not, let's clap for her on her way home. Yeah. And then I think we threw a couple curveballs at our AV group today and yesterday. So I just wanted to thank the AV team for hanging with us and making sure that we got all the kinks worked out. So thanks to our on-site team. And of course, these meetings don't happen without the help and interactions of our industry partners. So a huge thanks to all of you. We appreciate you being an active part of our community and hope that you'll continue to join us. And many of you may not be aware, but we also have a lot of philanthropic partners, including individual families who continue to contribute. Some of them were online, some of them have asked for the recording afterwards, and the work and the conversations that we're having are extremely meaningful to them. So thank you for again being part of this community, and please find friends to bring next year. Ooh. So I hope you've enjoyed it. Please feel free / pick up a lunch. It's boxed, so you can run with it to your car if you need to. And then hopefully we'll see you soon, whether that's at the next retreat or in Minnesota. Thank you.
Yes. Or no, good. Maybe. Yeah. Well,